very good morning and welcome to the live stream of the first session, session 5 of today, Amblyopia Free Papers. Today we start off very welcome to everybody here in the church and very welcome everybody joining us from the live stream. We start with the first speaker of the day, that is Sjoukje Loudon. Sjoukje Loudon is famous for the compliance studies on amblyopia, and today she will talk about her newest research, randomized controlled trial comparing dichoptic games with occlusion therapy for amblyopia.
Thank you. Good morning, ladies and gentlemen. Thank you very much. Maybe a bit out of the comfort zone of screening, we are now at the other end of the spectrum dealing with treatment for amblyopia, and specifically comparing two treatments for amblyopia. We did a randomized controlled trial comparing dichoptic action video games using the VR goggles with the standard occlusion patch for amblyopia. And I'm standing here, I was the PI, but the bulk of the work was done by Aveen Kadam, she's my PhD student, and Emily Tan, she's our research orthoptist. So they did most of the work, I'm just here presenting it. We have no financial interests, very many sponsors who we also like to thank. Just a brief background, amblyopia is the most common cause of monocular visual impairment in children and defined by the presence of an early amblyogenic factor, either an anisometropia for which we give glasses, or strabismus. We can have a combined cause of amblyopia or deprivation amblyopia by either ptosis or a unilateral cataract. As you've heard yesterday, we have a very extensive screening program in the Netherlands, and the eyes are screened from birth and visual acuity is measured at the age of 4 years before the children go to school. And the standard treatment in the Netherlands is still the eye patch, patching the better eye for several hours per day. It's a very effective treatment that has been proven. However, its success is hampered by poor levels of compliance, ranging from parents doing absolutely nothing to parents doing about 60%. So mean compliance with occlusion therapy is about 60%. We did, as Jan Rudolf said, we did all these studies with the occlusion dose monitor, which I will explain a little bit later how it works. And we looked at ways if we could improve compliance by not necessarily educating the parents, but by developing an educational cartoon story which was aimed at the child, explaining the necessity of the eye patch to the child. And this improved compliance significantly. That was my study, and Angela Cham did a follow-up study, and she looked at the when giving the educational cartoon story, specifically in low socioeconomic areas, this improved the rate of visual acuity improvement. But still, especially from North America and Canada, there came these studies saying, no, the patch is boring, we need more interactive. It's a binocular problem. Amblyopia is a binocular problem, and treatment needs to be addressed binocularly. So in came the VR goggles and the games, the Tetris games. I'm sure you're all aware of these games. And all the published work said the treatment works. Mean improvement is about 1.5 to 2 lines. However, the main issue again is that they didn't measure compliance electronically, so there was no way of knowing that the parents actually did what they were supposed to do, thereby making a valid comparison between these two treatments very difficult. So we set up this study in 2016 with a purpose to make a valid comparison between the effect of patching therapy and the dichoptic action video game in children with amblyopia. And the primary outcome was visual acuity improvement in logMAR per time period with electronic monitoring of compliance in both groups. So how was this done? We recruited all newly diagnosed amblyopic children in four clinics who were aged 4 to 12 years old. We did a cutoff at 4 years old because we knew from the literature that the younger children wouldn't be able to play the game, so we had a cutoff at 4 years. And it's also known that if the angle of strabismus is larger than 30 prism diopters, they would not be able to fuse the two images. So they all had a 16-week refractive adaptation period if that was necessary. We looked at compliance with the we looked at compliance with spectacle wearing. If amblyopia still persisted after 16 weeks, usually after 16 weeks, amblyopia had improved to 0.1 logMAR line difference, and if that was the case, they would be referred back to their orthoptist. If amblyopia was still there, they were randomized to either the patching group or the gaming group. And if you were randomized to the patching group, you would have to patch your child for 2 hours per day. And we looked at compliance with this occlusion dose monitor. It measures the temperature difference between its front and its back every 2 minutes. And it stores it in its memory, and it has a memory of about a week. So after a week it was collected and the data was read out, and we could see exactly when and for how long the patch or the glasses were worn. If you had been randomized to the gaming group, you had to come into the clinic. So this was in the clinic for 1 hour a week for 24 weeks, and the parents needed to come in every week for 1 hour of gaming. And every 6 weeks we measured visual acuity. That was done by Emily Tan, the research orthoptist, stereo acuity and contrast sensitivity. And what we also did is that we were interested in the experiences of the parents and the children to see if they had a preference for either treatment. So this is the setup for the game therapy. It's based on the principles by Dennis Levi. Dennis Levi's game was a little bit aggressive, we thought, for the children. So we had a company in Haarlem who made it more child-friendly. It's a snowman, so the snowman appears, and the child is instructed to throw snowballs at the snowman for extra points. It's in a VR headset, and the VR headset is big enough for the child to wear its own glasses underneath. This is my son. And we took him to the clinic, and you can see the setup. So this is the laptop here in the distance, and you can see on the screen of the laptop exactly what the child sees in the VR headset. Because what needs to be done is, you can see this is what the child sees in the headset. The left eye is the fellow eye in this case, and this is presented to the left eye. This is presented to the right eye, which in this case is the amblyopic eye. And what needs to be done is the contrast and the luminance of the fellow eye needs to be reduced based on what the child sees in the VR goggle. So this is something done subjectively, which makes it difficult for the younger children to be able to comprehend what we ask them to do. The second task the child needs to do is the alignment task. So this half cross is presented to the left eye, this half cross to the right eye, and the child needs to be able to fuse the two images. So they are asked, do you perceive this cross, yes or no? And these two tasks are done every time the child comes into the clinic before they start their treatment. That's what makes it complicated for them. So I'm going to go over to the results now. So we recruited children for 2.5 years, and we were able to collect 100. We discussed participation with 89, and 29 parents refused. They refused to participate mainly because they thought the game would be too time-consuming. They didn't want to come into the clinic every week for 1 hour. They had other children to attend to, and they thought it would be too much of a burden. So 69 were eligible. They entered the refractive adaptation period, and almost a third of them did not have amblyopia after treatment with the glasses alone. So we randomized 35 children, 17 to the gaming group and 18 to the patching group. And even during treatment, 10 children dropped out of the gaming group, and 3 children dropped out of the patching group. So in the end, we had 22 children who completed the study. So we actually wrote a paper about these hurdles that we encountered during the treatment, because everybody is very enthusiastic, and it's nice to be able to offer them something else than the patch. Oh, a gaming therapy, children love to game. They do love to game, but not when they're told to game. So we looked at these problems, because it's not something new. People already know about these problems, but nobody really discusses them. So we thought it would be imperative to write a manuscript about them. And we just got it published last month. And the main problem was that they lost interest in the game. And you can say, oh, well, give them a new game, but each game was about 12,000 euros alone to develop the game based on these principles. So it's not something insurance companies would be willing to pay if you compare it to the price of a patch. So they lost interest in the game. They didn't want to come back to the clinic. Parents had difficulties getting them back. And then came the excuses. No, he has a test tomorrow, he can't come in. No, child number 2 needs to go to the ballet. All kind of excuses came. The younger children had difficulties with the game settings. We have a nice video of a 4-year-old girl who's just staring into these goggles and waving her hands, and she has no idea really what to do with the goggles on. The equipment was sometimes a little bit too large, and I said, so this is with the game settings, making the cross and doing the luminance and the contrast setting, and difficulties comprehending the game. Even, just throwing snowballs was difficult for them. And then, of course, there were because the VR set gets warm, the glasses get foggy, and the children don't necessarily notice them getting foggy, and this would lead to frequent breaks to be able to check if the glasses were still okay. So back to our patient characteristics. We had 35 children, equal boys and girls, and the children in the patching group were a little bit younger than the children in the gaming group. This was not significant. Most of them were anisymmetropic amblyopes, as expected because of our inclusion criteria. Visual acuity was about equal, and compliance with spectacle wear was about 76%, and compliance with patching was 81% with a large range. And compliance with the gaming, well, that was 100% because they had to come into the clinic. Now, if you look at visual acuity improvement, the green line is the patching group, the purple line is the gaming group, and on the y-axis is visual acuity. This is in the amblyopic eye in logMAR, and on the x-axis is the time in weeks. And you can see visual acuity improves in both groups significantly, but there's no significant difference at the end of the therapy between both groups. What you can see is there's a large, these arrow bars are the 95% confidence interval. For the gaming group, they're about twice or triple the size than for the patching group. And even if you correct for age and diagnosis, the significant difference remained the same. So conclusion, dichoptic action video game using the VR goggles and patching, they both improve visual acuity. In children, there was no significant difference between the groups. However, we had an enormous amount of dropouts in the gaming group, not something we actually anticipated when we started the study, mainly because of compliance issues. So patching is hampered by compliance, this is hampered by compliance, but different kind of compliance issues. It was time consuming, so when you have a patch, you can put the patch on the child and you can go do your shopping. When you do these VR games, you need to be in the house, monitor if your child is doing this game, yes or no. Jonathan Holmes did the iPad study. He gave the iPads to the parents to do at home, and the compliance was so low, he wasn't able to do a reliable statistical analysis on the effect of both treatment groups. logistical challenge, that was also with the patching, and especially the younger children. So we didn't really have a child younger than 5.5 who was able to do the game. They just didn't understand how to do it. And there's also the cost issue. So we had a research orthoptist who came into the clinic to sit next to the children, do this. So for practical implications, who's going to apply this treatment? And are you going to give the VR goggles with the parents to the kids at home, to do at home? We are still doing the semi-structured interviews to the parents and the children. And what's just something that was interesting, I thought at least, was that the parents who did complete the gaming therapy, they said they preferred to do the gaming because then they were not responsible for applying this therapy to their child. It was somebody else doing the therapy. So that's why they preferred the gaming. Well, we have a big research team. My colleagues in Rotterdam and the School of Utrecht, the recruiting clinics, and Professor Levi for sending us his game. Thank you very much for your attention, and if there are any questions. It's a bit out of the screening range, so maybe...
Yes, there's a question.
That's very interesting, and also I was a bit surprised that 1 week, only do it 1 week, the gaming, could be sufficient to train the eyes and the brain. So I wondered is that because of practical reasons that you have 1 week chosen, or is there a background that it really can improve only playing this game once a week?
Yeah, it's a good point. We did 1 hour per week for 24 weeks because the literature said that 1 hour of game, so 24 hours of gaming, actually 17 hours of gaming is enough to improve visual acuity 1.7 lines. So that's why we compared this total amount total amounts because it's the cumulative, it's not per day, it's the cumulative amount of treatment received. And when we actually started this study, most of the literature was still in adults, not in children. There.
Hi, did you calculate the attention to treat versus the intention to treat and compare that into the two groups? Yeah, which is a classical epidemiological way of doing it.
Yeah, no, we're still working on the graph I showed you. That was only a couple of weeks ago. So we're still in the process of looking at that because there was a large range of compliance as well. So we need to correct for compliance, etc. as well.
I have another question from the chat. It's from Maria Fronius. She's not in the session right now, but she's in the chat. What about compliance with spectacle wearing, and was it age dependent?
The compliance with spectacle wearing was not age dependent. What was the eerste?
What was compliance with spectacle wearing?
Yeah, it was actually lower than with the patch, which we thought was a bit surprising. We're looking into that as well, because we have children who wore their glasses very well, because if you didn't wear the glasses, you were not randomized. It was very strict. It was kind of it's not a wild type study.
But was it in any way age dependent? Did the younger children do better than the older?
No.
Any other questions for Sjoukje? Yes? There, Tessa?
Have you suggested to continue this game at home by mobile phone, because I very often suggest to parents to continue this training at home.
Yeah, but
during patching, during time of patching.
No, because we wanted to see pure the effect of patch. Yeah, so that's if you want to look at, if you look at the reviews, there are lots of reviews now which have been published, comparing patching with glasses, comparing patching with the dioptic video game. But if you look at the literature closely, it's either patching and dioptic action video game with glasses. So it's not only patching with only dioptic video gaming, and that was the purpose of this study, to compare just the effect of that one versus that one, not patching and then so 1 hour of patching and then 1 hour of gaming. It was pure research.
Okay, thank you. Thank you. We move on to the next talk. That will be me.
Yeah, that would be you. So Jan-Olof Polling is our orthoptist doing his PhD in many things amongst myopia, but we also have a very big study in Rotterdam, the Generation R study, and we've looked at ophthalmological findings in this study population.
Yeah, thank you for the invitation. Really nice of the organizers to invite me. I will explain something about what happens after screening. So I will explain what amblyopia is left after vision screening in the Generation R study. I have no conflict of interest to declare. So the gold standard for vision screening is still for detecting amblyopia and refractive error is still visual acuity. And amblyopia is the primary target for vision screening in young children. We screened at the age of 6, or it was not a screening, it was a study. And most pediatric ophthalmic eye problems would have been then demonstrated by the age of 6. Good to know is that you would see that in the prevalence of amblyopia in screened populations is much lower than in unscreened populations, and we would like to investigate if this was the case in the Rotterdam children. So our research question is to report on the prevalence of these ophthalmological findings in a pre-vision screened and treated cohort of 6-year-old children in the Netherlands, and we wanted to know the medical reasons for low visual acuity and also the impact of the diagnosis on the visual acuity. And we used the Generation R cohort, and that is a Rotterdam-based cohort of Rotterdam children being born between 2002 and 2006, and it's nearly 10,000 children being born in this cohort, and they're all in the study. And we investigated them at the age of 6, not only 6, but also 9 and 13, and they're showing up for their 17-year investigations right now. So we're further down in the study. So getting the data was really difficult. So we asked if there was a contact with an eye specialist at the age of 2, 6, 12, 18, 24, 30, 36, and 48 months. And then again at the research center at the age of 6, so we knew that whether there was a contact with an ophthalmologist or orthoptist or optometrist or who with an eye specialist. Then we performed the visual acuity at the research center with the LIA symbols, we referred all children having a visual acuity of worse than 0.1 logmar, then there was further workup. And so there are two groups. There are the newly detected, so the people who had a visual acuity worse than 0.1 logmar, and there was the persons who had already been in contact with an eye specialist. So we could compare these groups and see the differences between these groups. And for the children who were known with an ophthalmologist or orthoptist, we obtained the medical charge and to see the history of the child. So we defined amblyopia as a logMAR visual acuity of 0.3 or worse in the amblyopic eye. There had to be an intraocular difference of 2 lines or more, and there had to be an amblyogenic factor. So all these 3 measures were entered into the database, and then we could see whether the child was really amblyopic or not. And we code the strabismus according to a national system, and it is comparable with international systems going around. And that was done by the orthoptist who send in their medical charge. We used the guidelines that are available. So these are the APOS criteria for amblyogenic factors. You probably all know them. And this is the first slide of the results of the study. So we called all these 10,000 children, or nearly 10,000 children, and almost 7,000 children participated in the exam. We had a visual acuity measurement in almost all children, or 96%, almost 96% of the children participated in this exam. We had 323 children being referred because of a not good visual acuity, and already 8.5% of the children received eye care. And then in the children who did not have a visual acuity measurement, and that was because of the failing of the equipment or anything, or there was no time left for this exam, in those kids there were also some referred children, but also some who already received eye care, but that was not statistically different than the other group. So the population looked as following. We had children coming in just over 6 years old, and half of them were girls. There were more eye exams or more eye care used by children with a premature or a lower birth length, and also a low birth weight. So these were significant findings, and also people with a lower socio-economic status used more eye care than the other, so low income and less income and low education were associated with more eye care. Then looking at visual acuity, you could see here on the right in blue the visual acuity in the better eye. Both eyes had a visual acuity. This is a healthy cohort, right? So you wouldn't expect any problems with eyesight. So the median visual acuity in both eyes was good, and for the better eye, it was the interquartile range was 0, and in the interquartile range in the other eye was 0.1, so slightly lower, but not very different from each other. Interesting are these children, these 55 children who had a visual acuity of lower or worse than 0.3 in the better eye. And these kids, more than half of them already received eye care, so they were in the picture of the eye care providers. More than a third had amblyogenic factors, and the rest was mainly refractive error was the cause for that thing. And also what was notable is that 80% performed a better test in retesting clinic, so that so the orthoptist just squeezes a little harder to get a better visual acuity. So this is the distribution of strabismus subtypes. We also asked the orthoptist to code them. So this is what you mainly see in your orthoptic clinic. So nearly half of the, or more than half of the population, or your strabismus types, is accommodative esotropia, either partial or fully, and then intermittent exotropia is also 1 in 5. And then you have the special forms, which includes the infantile esotropia, but your Duanes and your Browns and all kinds of things. Then ESO, EXO, other, and also the primary micro-esotropia is also a proportion that should not be missed. So we looked at visual acuity in relation to strabismus subtypes. And what you see here on the left is, again, in the best eye, in the better eye. And on the right, you see the amblyopic eye. So the red is the amblyopic eye. And you see that certain diagnoses tend to have a worse visual acuity. And especially the primary microesotropia still has, on average, a significant amblyopia. But what also could be seen is in the better eye. So in the better eye, and this is not what we see in clinic, that the non-strabismic had a very good visual acuity, but also the better eye in strabismus has a suboptimal visual acuity. And that is a significant finding that has been described before. So amblyopia in relation to what we have found in the different groups. So if we have this definition of amblyopia, we found in total still 31 with a residual amblyopia left. Of them, 26 had already received eye care, and the newly detected were 5. So we still had 5 undetected cases of amblyopia. In relation to the strabismus subtypes, I already said that half of them still had amblyopia. So half of the primary microesotropia still had amblyopia. Constant esotropia, the fully accommodative, they don't have as much amblyopia. And 1 in 3 partial accommodative esotropia also has this. So the equivalent of this worse than 0.3 logmar was 84 out of the newly detected children. 2 were caused by strabismus amblyopia, 3 with a subnormal visual acuity without any eye problems, and 79 were because of refractive error. So this truly significant amblyopia was only in 2 persons. And 74 again had a better visual acuity when they were tested by the orthoptists. So it is a healthy cohort. So we found a prevalence of strabismus of 1.7, which is slightly low, and that is because it is a healthy cohort. You don't go to a screening if you have a already diagnosed strabismus, probably, although strabismus was not the outcome of the study. They did a general examination. The literature prevalence of residual amblyopia in screened population is 1%, and we found 0.5%. No population-based literature on many of the eye conditions that we saw, and also in strabismus subtypes. And we had a 2-step referral with cycloplegic refraction, so we didn't measure all the children. That is a downside from this study. So in conclusion, the median visual acuity in these kids is really good. 51 children presented with a low visual acuity, and 1 in 5 explained by uncorrected refractive errors, and more than a third was explained by amblyopia. Prevalence of strabismus was 1.7, and accommodative esotropia represents half of the cases of strabismus. And the visual acuity in the better eye of strabismus is reduced, and the prevalence of residual amblyopia is 0.5%. Mainly the manifest esotropes, those are at risk with a residual amblyopia, and your constant esotropia is your micro, and your partial accommodative esotropia should be the primary focus on your amblyopia treatment. Thank you for your attention. Good.
Yeah, Rudolf, fantastic, this enormous study where you will receive your PhD on the 22nd of September. It's been a very thorough, dedicated work. My first question is 0.46% residual amblyopia. That has been described in Swedish studies. So in Sweden they say it's 0.5, whereas we found 0.85 in Amsterdam in the Ramsey study. But the question is, there is also decreased visual acuity because of uncorrected refractive error.
Yes.
And then it's the question whether you would not still consider that as minor amblyopia. So,
yeah,
so that would increase the 0.46.
Yeah, that's a good point. So that's a difficult question to answer with this database, because we would have then have to look into the persons who have. Then you must be sure that these persons also have a amblyogenic factor. That is definitely so. I have to distinguish between the persons who have amblyogenic factor and just a standalone refractive error. Yeah. And that is important. That's a good point to take home, and I will look in the database again to see if I can detect these people. But that is a good point. However, I also would like to make a remark that the Ramsey study used a different cutoff point for amblyopia. Yeah. So then these studies are difficult to compare. There was this Lancet review by Hugo Rai explaining the different criteria, and we took the one that was used most.
And then secondly, in the PhD by Freya Sloot on the 8th of September, the article, which is already online with Acta Ophthalmologica, but not being assigned to an issue, not published on paper, it is clear that the diagnosis of the cause of amblyopia is different in the same child at different ages. Yeah. So the criteria for differentiating between refractive amblyopia and strabismus amblyopia do not change, but the degree of anisometropia decreases slightly over time, so that you get a shift in cause of amblyopia. So very critical in your listing of causes of amblyopia is the age at which the diagnosis, the cause of amblyopia was made. So at what age did the orthoptist decide what kind of amblyopia this was?
Yeah, well, the generation R cohort is a prospective study, but this is a retrospective analysis. So that is difficult to obtain. We only ask for these information after the age of 6. Yeah. So we then go back to the orthoptist and to see what's the first eye contact. So we have slightly, but that is probably not too reliable data that we have on that. So unfortunately, that was also very good. points. Thank you.
Okay, I think we need to move on to the next speaker.
Yes.
If there are no many questions. Mr. Dongsheng Yang from China. Yijinan, yeah. Manit? Not here. Who will talk to us about a new binocular therapy for refractive amblyopia.
Hello, everyone. Many thanks to Dr. Simmons for the opportunity. My name is Dongsheng Yang. I am a pediatric ophthalmologist, work in Jinan Puri Eye Hospital, belongs to Bright Eye Hospital Group. In the next few minutes, I'm going to show you a new method for refractory amblyopia treatment. Introduction. Placing a neutral density filter in front of a better eye reduces the luminance, but doesn't change the contrast a lot for that eye. So it is argued that if the variant neutral density filters works for monocular amblyopia or not. There are proposals to using the neutral density filter for amblyopia treatment from laboratory work, but no clinical report available. However, we placed neutral density filters in front of a dominated eye to balance the visual acuity of each eye and obtain significant visual improvement in patients who have failed in atropine and patching treatment. We investigated the effect of neutral density filter on amblyopia because we believe that this method is much more cost-effective than computer-based binocular therapies and bandage film. A Snelling chart was used to test the effect of a neutral density filter and to select a specific neutral density filter for an individual patient. The luminance of the Snelling chart was measured using the luminance meter. With the light on, the luminance of white background and the black letter of the chart was measured and listed here. The contrast of the light chart was 97%, which was calculated using this formula. To simulate a daily life visual condition, we turned off the light of the chart, the luminance of white background, and the black letter of chart was such and such respectively. The contrast of the chart was 95%. This light-off condition was used to select a neutral density filter. To control the room brightness, dark curtain was used to block light from outside, and the ceiling fluorescent lamps was used to light the room. The luminance of the lamp was measured and shown here. Effect of neutral density filter on luminance and contrast of a Snelling chart and the light on and the light off condition was tested. We placed the neutral density filter in front of a luminance meter and measured the luminance of the dark letter and the white area of the Snelling chart. As you can see here, the neutral density filter, when it's not on, here is the luminance and the contrast. And when the light off, the luminance and the contrast. As the numbers goes up, the contrast, the luminance and the contrast in each condition dropped dramatically. Here is the pictures for those tests. As you can see, here is the contrast. As the neutral density number goes up, actually the contrast also drop. But on the luminance, when the neutral density filter goes up, the light off condition, so the luminance drop dramatically. 4 patients with refractory amblyopia who had failed to respond to occlusion and atropine penalization therapy was treated using the neutral density filter. We placing a neutral density filter in front of the dominating eye and adjusted its density so that the visual acuity in the dominant eye was 1 line lower than in the amblyopic eye. The selected neutral density filter was attached to the glasses. Subject wore the glasses during their waking time and as long as possible during their daily activity. Intervals for follow-up visit was 4 to 6 weeks. Neutral density was adjusted to be shallower when the visual acuity of the amblyopic eye improved more than 2 lines. It was showing that the best corrected visual acuity of the amblyopic eyes was significantly improved for more than 4 lines on average in 16 weeks. Stereopsis was improved also. Case number 1, who is a 46-year-old man. His vision improved from 2033 to 2025 in 10 weeks. Actually, this patient had exotropia that was corrected. Then the treatment started after the correction. Case number 2, a 36-year-old woman. The visual acuity in the left eye was lower, it's 2033, and improved to 2016 within 10 weeks. And also stereo acuity improved from 60 second of arc to 40 second of arc. Please pay attention to the age of these 2 cases. One is 46, this one is 36. They are quite unusually old for the treatment of the amblyopia. Case number 3, a 9-year-old male student. The visual acuity was low in both eyes, as you can see here. And after 16 weeks, her stereo acuity was improved from 100 minutes a second of arc to 40 second of arc. Interestingly, not only the amblyopia eye improved vision, but also the eye with neutral density filter also improved, which is very interesting. Case number 4, a 16-year-old female student. Her right vision was 2032, as you can see here, and after 16 weeks, her vision was improved to 2020. Also, his stereo acuity was improved from 200 second of arc to 40 second of arc. Conclusions. Wearing a neutral density filter in front of the dominant eye improves vision and stereopsis for refractory amblyopia. It indicates that neutral density filter wearing on dominant eye may be an alternative way for amblyopia treatment. It is important to turn off the light when neutral density filter was selected. What's the mechanism involved here? Is this because the binocular cells was turned on? Thank you for your attention.
Thank you for the presentation. Are there any questions from the audience? Herb.
Somebody else.
Dongsheng. Dennis, kun je Dongsheng in beeld zetten? Oh, Dongsheng, you have audio only. You're doing this research in Jinan, in China, which is halfway between Beijing and Shanghai. So this is not easily done research. I have two questions. You say these patients were not responsive to occlusion therapy in glasses, but I would then think that they had not worn their patch. They were not compliant with patching therapy, possibly, because otherwise I cannot imagine that visual acuity would not improve to patching, whereas it would with neutral density filters. And then secondly, if you treat adult patients in this way, I'm sure you can get a few lines of increase of visual acuity. I had a patient who had treatment for a tumor in the better eye, and the visual acuity in the amblyopic eye improved 5 lines, and she was 50 years old. But would you then call that treatment of amblyopia? I mean, is it going to stay?
Is he online?
Yes. We heard a sound. His connection is not working.
If you are unable to respond, you can also chat your answer, and then Jan Roelof will read out your answer. Or you can send it by WeChat. I was in China, so I now have WeChat.
Any questions? Okay. We can. Would that be okay?
Yeah. Save that for later. Clear?
Ja, is dat Eline die kan praten of niet?
Okay.
Hij zegt dat de verkeerde PowerPoint getoond werd.
Dat kan ik niet terughalen. Komt deze nu of niet?
Discussion. Would that be okay?
Yep.
Until the beginning of the next session number 6, implementation of vision and hearing screening programs. Okay.
Next section, and invite Dr. Luisa Montero for talking about hearing screening implementation in Portugal.
Good morning, everyone, and a special thanks to Professor Simons for allowing me to tell you our experience. So I work in Lisbon, and during almost 20 years I've been connected with the implementation of the newborn hearing screening in Portugal, although in an informal way. So, like in most countries, we performed high-risk screening, not universally throughout the country, especially in cities, large cities. And in 2002, we started small experimental programs that tried to be universal. All the programs were hospital-based, and the teams and the children themselves were invited, so it always worked on a voluntary basis. And the screening programs were organized concerning the indications of the Joint Committee of Hearing Screening of America for the year 2000. Then voluntarily again a group of professionals tried to implement and to create some rules. So this is the initial steering group, and this steering group was composed of mostly ENT physicians, audiologists, pediatricians, and nurses. So what we tried to do was to write recommendations, adapted recommendations for the Portuguese reality that could be acceptable and implemented. And we wrote recommendations that were endorsed by the scientific societies, namely the ENT Society, Pediatric and the Audiological Society. Then we started training the screeners and the people who would be in charge organizing local programs. And we also had to find funding to buy the equipment, because the national health system were not interested in funding us, so we had to find funding elsewhere. And lots of corporate companies gave us money, and we were able to provide equipment for almost all the maternities in Portugal. And we also started campaigns for public awareness, and also to lobby with the stockholders, and especially the National Health Service responsibles. But we were not very lucky in that last task. So what is the national situation by now? Now we have guidelines that were incorporated in the implant cochlear guidelines. So it was an opportunity when we regulated access to cochlear implant in children. We could incorporate some guidelines concerning the screening. And since 2015, there are guidelines. Prior to them, only local committees were responsible, hospital-based committees were responsible for the implementation and organization. What I think it's not such a good idea, because the results are very variable. So quality assurance programs of the hearing screening theoretically are imposed by the National Health Organization, but in practice they never happen. So the results were never audited. At the current time, we have only a small amount of data, and their quality is very variable. annual reports are not yet available. What are we doing? Since the beginning, we had to separate screening programs, one for Well Baby Clinic and the other one for NICU kids. And this is not, that was not very hard to implement because we traditionally had the high-risk baby screening program. And we use the 1-3-6 rule, 1 for screening, 3 for diagnosis, and 6 for intervention. I can share now with you the results of an informal survey that was conducted regarding, last year we conducted this survey regarding the 2019 births. So a questionnaire was emailed to almost all ENT head of departments concerning their results. And this is one of our first difficulties, because sometimes we are not sure who is the responsible at each hospital. So perhaps because it's easier for us to contact the ENT head of departments, and sometimes they gather information with the neonatologist or the audiologist. It was a voluntary survey, and we realized, we could confirm that most of hospitals don't have electronic data. Some of them don't have any data at all. They just perform the screening, the first, second, and hopefully the third diagnostic stage, but they don't collect the data, and they are not aware of the outcomes of the screening. So, although we know that the coverage of the screening must be near 100% of newborns, we cannot prove it. There is no evidence that the screening is universal. So, in 2019, we had almost 87,000 births. And we could retrieve information on 75–6% of the newborns. Some of the answers had not a minimum quality to be incorporated in this survey. So we know that most kids are screened at least once. We had a coverage rate of almost 97% of those kids that were included in the survey. Second stage coverage is also acceptable. We see that the referral rate is 9%, and this is because most of the screening programs are OEA based. Almost all of them. So I think it's a regular reference rate, and 69% of the kids were submitted to the second stage. So we lost some of them between the referral and the second stage. The diagnosis coverage rate was about 2.1%. So we lost some of the kids also from the identification through the diagnosis. But 2.1% of this population was submitted to effective diagnosis. And we could identify in this population 146 kids with any kind of hearing loss. It can be unilateral, bilateral, low, moderate, severe, or profound, because that kind of accuracy could not be reached by the answers at our inventory. And also, we discovered that some of the kids, 4% of the whole population, had any risk factor. We cannot be sure of what kind of risk factor it is. Some of the hospitals gave us detailed information about the risk factor they found, but it cannot be used because the great majority of the hospitals don't have records on that. So, 16 years after working in this implementation, last month a working group was appointed finally by the National Health Authority. So hopefully the next 6 months we will try to reach some of the objectives of the working group. The main objective would be monitoring all the programs and gathering all the data so we can have an idea of the quality, and we'll try to equalize the quality of the programs throughout the country. We are also very interested in knowing the outcomes. How does the screening improve quality of life of children who are born with some kind of hearing disability? And another very important objective of this group is the implementation of what we are calling the preschool screening, because this is not done actually. We have some few experimental examples, and we are very keen to use the manual and the recommendations to implement de novo this kind of screening. Implementing the preschool screening will oblige us to form a network for referencing the identified kids in preschool age. So this will be one of our tasks. The other one would be applying for funding for the equipments for the GPs, the primary care physicians and nurses, to being able to screen preschool kids. In conclusion, although universal newborn hearing screening is implementing throughout the country, due to the initiatives of health professionals, and this is our experience, is a bottom-top experience. It lacks central monitoring and quality control, and we are hoping that this newly appointed working group would be able to implement and to correct everything that needs to be fixed in the screening program. And we think that the manual that this group were able to collect will be very, very helpful for us. Thank you for having me.
Thank you very much. It was very interesting to see that your figures were very much similar to the figures I presented from the average from the EUSCREEN.
Well, I'm not so happy because I think there is a bias, because only the people who had a minimum of organization respond to the questionnaire. So there is 25% of screeners and programs that we could not evaluate.
But now when you have the national health authorities behind you, this may improve. Yeah. Do you think so?
Yes, I'm very, very expectant.
So what do you think is the key factor behind to get the monitoring and reporting done?
Well, I think the key factor would be to appoint someone responsible, an administrator for the whole country, and to being able to have a electronic platform, and that everyone can, in a timely manner, report their results. So we can monitor and we can act when something seems not to be right, in a timely manner.
Yeah. Are there any other questions from the auditor? Yes?
Thank you for this nice presentation.
Thank you.
Many things are similar from Flanders and population, number of children you screen. Maybe I was a little confused, but I would like to ask, if you look at the general population you have screened, how many percentage of them don't have any risk factor? Babies who find...
Well,
so that's sometimes
most of them don't have, because only, I don't remember the numbers, but only in about 2% of the cases, one risk factor has been identified. I can tell you that there are some hospitals that keep very good quality data, especially in the NICU population, premature babies, and what we see is that most of them don't have just one risk factor, they have several risk factors. And so that is a huge, very important group, because we know that almost 50% of the hearing loss kids will come from that group. So this is a very important group for us, and we'll try to analyze it further.
Okay. We are behind in time, actually.
Yeah, very good to see the involvements and the hard work you did to have these numbers, if you have but it seemed that protocols are quite similar then, but they all have 2 steps.
Yeah.
So is that regulated from above, or has everyone chosen?
It's a recommendation, and because OER equipment is cheaper and is more easily operated, we implemented OER-based screening, but a few hospitals have the opportunity to proceed with automated ABR whenever they find a referral baby in any of the stage, first or second stage. But mostly it's a 3-stage based protocol.
Okay, so, but it's on local initiatives, it may change, okay.
Okay, we also have 2 questions from the chat here. So there is Maria Pinto. And don't you think that it is very important to have audiologists in the NHS in the programs all over the country? In ACES, what does it mean?
Well, we have audiologists working with us. Most programs, screeners are audiologists nowadays. So they are very involved in the screening process.
So that's the answer to the next question, because she says, why aren't the Portuguese audiologists mentioned in this work? So
well, but they are. They are? Yes, they are always present. They were present in the steering group that is still working. And in this working group, there is also an audiologist who is currently the head of the Portuguese Audiological Society. So audiologists are very well represented in every part of the process.
So what does ARS mean? Stands for ARS. Capital letters, AR. Why not in the ARS? I don't know what AR is.
Yeah, I cannot understand the question. I'm sorry.
No?
I don't understand the question.
Shall we ask her? What is ARS? I think otherwise we have to move on. Not.
I'm sorry. Well, what I can tell you is that nowadays we have a very good number of audiologists, and every screening or diagnosis step is performed by audiologists. Usually nurses don't do it anymore. In the first times, yes, but not nowadays. And they are, of course, involved in the process of diagnosis, rehabilitation, cochlear implant fitting. So they are always working in the group.
Thank you very much.
Thank you.
So then we move on to the next speaker, who is Lisa Rubin from Israel, and she's also talking about the neonatal childhood hearing screening program in Israel.
For my PCR test.
Good morning. I want to thank the EUSCREEN staff for the opportunity to speak, and for the many wonderful colleagues that have presented their works. I'm going to tell you a little bit about the challenges that we faced in the neonatal hearing screening program in Israel. Perfection is the enemy of the good, that one needs to compromise all the time. So our national neonatal hearing screening program started in 2010, but in more than 10 years previously, there were, as in Portugal, hospitals that had voluntarily initiated on their own fundings or with donations hearing screening programs. Most of those were OAE only, two-step. And the way that we were able to get the funding, we needed to do it nationally. Israel has national health insurance since 1995, though it was highly insured even before then. To earmark 42 new Israeli shekel, which is about, nowadays it's about 12 euro per screen for the infants from the monies that are paid to the hospitals where the babies are born. When we started the program, we needed to take into account that there were hospitals, and one of the health funds in the hospitals that they run were already running programs, and that they did not look kindly upon changing not their protocols but their equipment, because they had data and studies going on. And so we needed to, although we would have chosen perhaps buying equipment nationally, it would have been cheaper, and we would have chosen the equipment that we wanted. We knew that in doing that, we would generate enemies rather than partners. And so we just compromised with that. We also didn't use stated cutoffs. I know that's kind of strange, but that was part of the accommodation. Everybody was using 35 to 40 dBs. But we stated in the protocol what was considered a fail, whether it was a one-sided fail, two-sided, unilateral or bilateral fail, what was supposed to be referred. And in addition to that, we said how many times you could do the OAE and ABRs rather than, so it was a two-step OAE, you could only do it 2 times. And the ABR was to follow and only done 1 time. And the other part is that all infants in Israel, with the exception of one of the hospitals where the most births take place, the child stays the mother and the child stay in the hospital for 48 hours. That's to actually accommodate neonatal metabolic screening. But we took advantage of that. Somebody else did that hard work. And in the other hospital in the south, the children there's special dispensation for them to be discharged at 36, which means that for some of the children, you have to accommodate 3 tests within a very short amount of time when there are lots of other things that are happening. The protocol or the directive that we sent out also required reporting. But at the time, it was aggregate reporting, and we'll talk a lot about that. So one can look at it. I worked in this as a pediatrician, preventative health care, and the regulator. But really what we want to make sure is that every child is screened, and every child that's screened is follow-up diagnosed, and that's ensuring seamless care. And that is not so easy, at least in Israel, because there are different care providers. We have 4 health funds. Hospitals are separate from the health funds, except under some occasions, and it has nothing to do with where you're born. They're different record systems, and they're the privacy laws. So as soon as we instituted our health care, our program, we tried to add hearing loss as a reportable condition, because congenital malformations are reportable, and then we would have a tool by which we could then get information legally and move it on. Well, that was in 2009 when we started working on it. It's 2021. Guess what? It's still happening. Providers, who's responsible for what and who pays? Births are not covered by national health insurance. This is another little anomaly in Israel. It's covered by the National Social Security Institute. Curative care, ambulatory and hospital covered by the health funds, and preventative care, screening programs, the government. They're all different record sources and different funding. So not so easy. And when we want to report, the baby's born in the hospital. It's covered by national insurance, national health insurance, but the Social Security, the hospital doesn't know which health fund the baby is being discharged to, because it's not done in the hospital. The baby's not born yet. So about 2 or 3 years ago, we've been working on the birth record file and trying to transfer it, to push it to the health funds, because they wanted it, understandably. They wanted to know how many preterm babies. They're not so interested, they weren't so interested originally in the results of this screen. And we figured out a way, and they are now, the health funds are distributed a list of all the babies that are purportedly in there with about 90% accuracy, and they return reports of babies that, for reason or other, and they usually do it by allocating it to the mother's health fund, because usually the mother registers them in the health fund. But this simple step is not to be understood just generally. So that was problem number 1. The diagnostic testing after you've passed or failed your hearing screen is done as responsibility of the health fund. It's not the responsibility of the hospital. It's not covered by it. That's a whole different system. How do we merge those? And how do we get the information that that's been followed up, that's linked? So that's kind of problematic, and the testing is most frequently done in the hospital. But then how do you get that back to the health fund? One of the health funds has, they've now developed their own system of doing the diagnostic testing within the health fund itself, and they said, wow, we want the results of the screen. And I said, we've been working on this a long time. Good, you'll be the pilot, right? And then we have habilitation. That's done in a totally different, and it's not even in the health system, right? Some of it's the health system, but there's also the welfare ministry, the education ministry, and of course Social Security. But all these problems, they also generate opportunities for getting information from different sources. So even when it's so difficult, the National Insurance Institute pays a stipend for disabilities, to children with disabilities. And they have some of the best data, okay, because they're paying money, and so they really follow the money. And they have good information. It's not very easily available, but we were able to bootstrap for Evelina and the model information about how many children were diagnosed were getting their disability stipend by 1 year, 2 years. It's reported that way. And it's a possibility of getting that information in the future as well. So we have Band-Aid solutions, what I call them, for getting the data. One is what I said was mandated by the directive, and that's aggregate reporting by the hospitals. They get a little piece of paper, sent digitally, of course. We do it only digitally. And the hospitals and the person who's responsible for the screening, usually the audiologist, always the audiologist, excuse me, they have given a form in which they're asked how many babies were discharged from the hospital, you know, how many were administered OAEs, how many did a full protocol, and how many, and divided up by low risk and high risk. Because it's aggregate reporting, and we've built into the form ways of checking to see whether the data is accurate. It's mostly accurate, but it's not easy. And it's very hard for the hospitals because they all have different methods of calculating their data. It's aggregate, so it's no solution to seamless care. It doesn't provide any information to the health funds and tell them who needs to be followed up. And as I said, the reliability is somewhat problematic. We've done chart surveys of rehabilitation centers for looking at the age of diagnosis and rehabilitation, and we know we did it before and after. We did it before and after, and we're in the process now of doing a rerun of that survey to see where we stand now, 10 years after the initiation of the national program. And we know that the program has made a difference. It reduced significantly the age of diagnosis. It reduced even more significantly the age in which children were entering rehabilitation. We know it by Arabs versus Jews, which is minority versus majority population, but it's not real-time monitoring. We need to know that in real time. And it doesn't solve the problem of non-testing. And the National Helsinki Committee, because this is something that's done in all rehabilitation centers, they've said that we've approved it to you this time. You're never getting an approval again because you're not allowed to look at those health charts. You need to do it in the new system, which I will tell you about shortly, except that the rehabilitation system, the rehabilitation centers are not linked to the new system, okay? And then we've done follow-up surveys of parents of infants with failed screens. We know with about 95% accuracy that the children coming into the well child care, they report on the results, and we can actually have their discharge summaries. So we can base it on the discharge summaries and not just parental report. And we know that we have 80% follow-up of failed tests. Again, it's not real-time monitoring. It was to see where we were standing. Doesn't solve the problem of non-testing. Again, it's periodic and non-routine. High tech, excuse me. That's what we think is going to be the answer. When we reissued the directive in 2018 regarding the healthcare screen, we sent to the hospitals, I'm going to go down to the bottom first. We sent to the hospitals a requirement to report the baby's test results as a code. We invented codes. We took the ICD and there's a committee, a national committee that does the codes, and we said, you tell us those are the codes, you put it down there, and then because every child is discharged with and it's all records, all medical records in Israel are digital at this point. We wanted to turn the results of the code into a data byte. And as of 2019, 75% of the hospital, or 75% of the babies, not of the hospitals, were already reported as a code. It's not ready yet, but we will be able to, again, because now we can take the birth record and we can transfer it to the health funds. The health funds will know. The health funds are not looking to be examined on it, but we'll work on it, and that will eventually happen. So that permits that to be transferred in real time to the health funds. And permits them to follow up the failed screens. And it'll permit a more accurate assessment of those aggregative, it's a line-based, infant-based, single infant, in order to know about the hospital. So we're moving to that. The other part of it is that Israel is committed, has a national plan for doing data sharing between the different health funds and the hospitals. and it's now, or it's the second iteration, it's called ATON, which means strength, and it links hospitals, health funds, well, baby clinics at this point also. It's a read-only. It has to satisfy the confidentiality and all the confidentiality rules. So if you come into the hospital, the physician in the hospital can access your clinic records as a virtual record. He can't copy it. He can't write onto it. He can't transfer it. It dissipates after a certain amount of time, but it's available. And the hospital records are, as a record, the summary is actually transferred to each of the attending physicians or the caring physicians. And they, you don't have to read it, but now the health funds actually monitor how many of those records are opened up and looked at. Well, looked at, I don't think but they can see whether you've opened it up, and they actually turn that into a quality indicator. So we have ways of transferring the information now that we didn't have 10 years ago. And we're working now in order to make that something. They're not perfect because some of the hospitals will be, even though they're supposed to do all the tests in 48 hours, will, for children that they haven't succeeded, will bring them back. They're required to bring them back on their own penny. They're not allowed to charge for it to finish the screening. But that won't go into the hospital record, the discharge summary. So there are still lots of kinks that we need to do in order to fix it. But we are moving closer to having actual real follow-up data. So we're not there. Coding doesn't specify risk or need, and we need to develop algorithms to designate the infant's risk status. Is the coding done real time? Another question. But there are other links. We can have a potential link to the hospital-based data on implants. We've looked at that separately and looked at when the implants are done, and we know that there's been a decrease in the age in which the implants are actually, cochlear implants are done. And as I said, we don't have a link yet to the provision of hearing aids and social and educational habilitation. And I said that it's not reportable. And the health funds are, as I said, not rushing to take responsibility. We need to work on that, but it'll happen. So 11 years later, the National Neonatal Hearing Screening is really considered a success in Israel. It's highly regarded. I didn't give you the data because I've presented that before. And we've decreased the age of diagnosis and age of entry to habilitation. It's increased equality. It's lessened differences. But we still need a sustainable reporting system for monitoring performance. And so I want to say that there has to be some sort of balance between what we demand at the onset and making sure that we have a plan for going forward to having better reporting in order to improve the program. Because otherwise we would be, if we had waited, we would still be waiting. Thank you very much.
So the discussion will be postponed.
About vision screening in Hungary. Welcome.
Sherfeze from Hungary. And thank you for the opportunity and to organize this meeting. And please allow me to...
Please speak a little bit loud.
Okay, sorry. Please allow me to introduce our health system shortly. Our system is chronically underfunded. The Hungarian population is a bit under 10 million, less than 10 million. Mostly we are living in cities. The health expenditure is under the EU average, and 1/3 of it comes from out-of-pocket payments. It means that this is one of the highest in the EU and twice of the OECD average. There are huge differences between cities and rural areas. The uneven distribution and shortage of health professionals undermine access to health services in Hungary. The life expectancy at birth is below the EU average. It's shorter, it's 5 years shorter. So this is the background, and let's talk about the vision screening. It is financed in Hungary by the state, the health insurance fund management, and carried out by health visitors. We have more than 5,000 health visitors in Hungary. They have a degree of Bachelor of Science. They are well skilled, but these screenings are really quite frequent. They visit the families and do other screenings, so the visual screening embedded in a general screening program. After the newborn goes home in the first 3 days, they are already visited, and they help in breastfeeding, give advices, they document all the percentages, the development of the child, and in every visit there is some ocular function screening. In the beginning they check the eye movements, they do cover tests, the pupillary red reflexes, and the pursuit movements, and then later on, after the age of 3, they do the uncorrected visual acuity test, they check the color deficiencies, and they use the Lang-1 stereo test to detect the stereo acuity. They are not orthoptists, we have no such a program in Hungary, unfortunately, but all screened children who has a positive result are sent to a pediatric ophthalmologist. I think we have a quite large referral rate and a high false positive, but all of the children, almost all of them are screened, nearly 99%. This is an outstanding rate globally. But I agree that we have a very frequent screening. And from year to year, if there is even a negative result, the next time there will be the same procedure. So it doesn't matter whether is it positive or negative. If the child doesn't take part in the screening, then the health visitor reports it to the child welfare service. The visitors are under the supervision of the GPs. They work together, but not in the same room, just in the same building. In Hungary, there aren't uniformized acuity tests. The protocol of the test was lastly reviewed in 10 years ago, so it's not that new now. We should renew it. Maybe it's this model, the screen model, will be a great opportunity to do that. This is one of our mostly common use tests. This is done by anisotropy. This has a logarithmic scale, but these signs are not monomorph. We haven't got a crowding effect. This is for non-verbal children mainly, and each part is a very cute face cover shield. But we have also other tests just for the pre-verbal, partly for pre-verbal children, and the screening is in the age of 3 and in the age of 4, in the age of 5 and 6, and after it in the school age, in every 2 years there is a screening for the visual acuity. The equipment differs and depends upon the financial income of the given region. There is no photo screening at this level. So in Hungary, we have a quite well-organized screening. The children are well covered. And now we have a cloud-based database. And I think maybe this can help us to do statistics. We have no data about the efficacy of the system. We don't know the sensitivity and the specificity of these screenings. But all of the data, either private or public hospitals, and even from the pharmacies, are sending now, in the last year, from the last year to the general database, and it can be seen by any of the other doctors and health professionals, and maybe it will help to avoid repeating duplicate examinations and treatments, prescriptions. The coding is a question, but if it will be correct, then it can help us to evaluate the screening. The disadvantage is that there are huge problems in the rural areas, lack of pediatric ophthalmologists. We would need more photo screening devices, and we have no orthoptists. There is no program for their training in Hungary, so there is a missing step between the health visitors and the pediatric ophthalmologist. They have a very low salary, but I hope that it will change in the future. Thank you for your attention.
Thank you. I have one question from Anna Horwood. She wonders if the vision screening takes place at the same time as other health checks, because that would be cost saving. Or is it separate visits?
There are no separate visits because this is so organized. Sometimes it's in the same time as the vaccination.
Okay.
So they go to the vaccination, and there is a several page sheet paper and the health visitor describes all the data, and this is so in Hungary. It's common.
Thank you. So thank you very much. And then Herb has a question.
If we compare the situation in Hungary with our recommendations for Romania, several parallels can be drawn. For instance, you also have the difficulty in the rural areas of reaching all the children. Then, secondly, you screen at many other ages apart from 4 and 5. And in Romania, we recommend to concentrate on 4 and 5 because it's by far the most effective. Is that not something that you could also adopt?
Yes, we have to lessen the screening periods. It's too frequent now.
Yeah. Okay.
Thank you for the advice. It won't be difficult. It will be difficult. We have to contact with the Society of Pediatric Ophthalmologists and with the health ministers, and we will see, because this system goes back to 1915. It's a very old system, and there is a huge number of health visitors, so it has renewed somehow, because this is the new model shows that it's not cost effective. And
you also need orthotists.
It would be a great help for us because we do everything. We have no orthoptists from the beginning to the end, and these visitors, they just check the uncorrected visual acuity, and it's not enough. So it.
And how many orthoptists are there in Hungary?
We haven't.
Zero.
Zero.
So you start a school of orthoptists in Budapest.
It would be nice to have one.
Yes, it would be good.
Thank you, Sheila. Sorry to say the wrong name. Sheila, what's your name? Thank you. And from a place with good organization, we will move to some place with maybe not as good organization. So we welcome Like Guma to talk about the vision screening in Rwanda.
Yeah. So welcome. I'm also in Amatkui, the eyes and ears in Rwanda. Let me see how I'm gonna. Yeah, my name is Like Guma. I work at the Rwanda charity eye hospital in Rwanda, but I also work in the Netherlands at the Rotterdam Eye Hospital. This is one of my patients the day after surgery. Later on, you'll see a photo of her the day after surgery. I'm going to tell you a little bit about Rwanda today, the healthcare in Rwanda, very little bit about the hearing part. Then we'll go to the seeing and the future. So Rwanda is a country, Central Africa, just below the equator. It's about 3/4 the size of the Netherlands. And the neighbors with Uganda, Tanzania, Burundi, and Congo. So you kind of know where it is. Yeah. They have 12.7 million inhabitants, and compared to the Netherlands, they're slightly more dense populated. But as you can see, Rwanda is really green. It's also called the country of 1,000 hills. And many people live on the countryside and are farmers. More than 50% lives below the poverty line, and at least 30% women per public body, and most women in the government in the whole world. So I think that's a good thing. Rwanda is mostly known for the genocide from 1994, where almost 1 million people were killed in 3 months' time. It was a war between the Hutus and the Tutsis, but those words are not allowed to be said anymore in Rwanda. You can't ask somebody if they were a Hutu or Tutsi. They say, no, we are Rwandan, we are one nation, we're looking to the future. And Rwanda is really a country looking to the future. It's a really clean country, there's no garbage in the street, and it's safe. I think it's even safer than some cities here in the Netherlands. I can walk around in the street on my own, which is something in Uganda, it's even more difficult. So healthcare in Rwanda. Almost everybody has an insurance, and it is based on your income, what kind of insurance you have. So there's one from the government, it's called the Mutuelle de Santé, and if you earn, well, if you're poor enough, you can get that insurance. And it's about 8 or 9 euros a year, and if you have that insurance, it covers 90% of your consultation, examination, medication. So you have to pay 10%, which means for consultation, you have to pay around 200 Rwandan francs, which is about 20 euro cents. So, but the general income is €1 a day, so for some people it's still pretty much. And if you earn more money, then you have to get a private insurance. So you have to pay, according to your insurance, you pay for your consultation. Almost everybody has the insurance, because if you have to go to a clinic and you don't have any insurance, you're considered as a private patient, and then you have to pay 100% of all the costs. So Rwanda has health center and district hospitals. We'll go into that part later. There are 3 eye hospitals, which is even more than we have here in the Netherlands, actually. There's 2 schools for the blind. There's 1 school for the deaf, and there's some audiologist nurses. But let's go to that part. First question, is there screening? No, there's no hearing screening. There are some audiologist nurses. I just found out last week that the Starkey Hearing Foundation trained some audiologist nurses in 2019, but I found last week. So I haven't had the chance yet to ask them how many people they trained. They can do some diagnostics. That's it. There's no screening program. And there's 1 school for the deaf, but it's all the way in the north of the country, and it's pretty expensive for most Rwandans to pay the school fees. Yeah, if we go to the seeing part, which I know a lot more about because I work at some eye hospitals there. Is there screening? No, there is no screening. First, I was a little bit confused why Rwanda is in this whole study, because like I said, there's no screening, but yeah, we can have screening maybe. So like I said, there are 3 eye hospitals, and let's compare to the Netherlands again, because we are here in the Netherlands. Netherlands has around 650 ophthalmologists, which is 1 ophthalmologist for every 26,000 people. If we go to Rwanda with 12.7 million inhabitants, where there are 20 ophthalmologists, there's just for consultation 1 for every 635,000 people. If you want to get surgery, there's only 7 ophthalmologists doing surgery. Not all of them are really good. Yeah, so that's a little bit difficult. This pyramid, it's really small, but I'm going to tell you what it is. It is made by the WHO together with the government of Rwanda. So there are around 45,000 health workers around the country in around 14,000 villages. And maybe some of you know the organization Vision for a Nation, they trained in 2017, I think, around almost 3,000 of those health workers to do eye screening. They don't do it, but they got a training. Then we have around 500 health centers, which is like a very basic clinic. You can get really basic care, but there are no really eye-related working people there. So if you have a problem, you have to go to a district hospital. We're only 34 in the whole country, and we have ophthalmic clinical officer working there. An ophthalmic clinical officer is like, not really an optometrist, it's half an optometrist. And they have some eye drops and they have some materials to do some eye checks and can treat like basic eye care. But if they still can't help you, they have to send you to a referral hospital where are some ophthalmologists working. And if you're lucky and you need surgery and there is a doctor there who can do surgery, you're in a good place, and otherwise you have to be sent to an eye hospital. So imagine you're on the countryside, and I heard the most crazy story one time. There was a chicken who had their nails like scratched the eye. So you go to the clinic, you go to a district hospital, then you go to a referral hospital, and then you end up at the eye hospital. Some days later, the eye had to be taken out. So the equipment is really different of all these places. And for example, the autorefractor is something which needs to be checked every once in a while if it's still functioning. But nobody knows how to do it. So also the equipment, it's not always the best quality. If we go to the staff, for example, retinoscopy, for the hearing people among us, retinoscopy is something how you check the eyes, for example, for children, how to measure what kind of glasses they need. There's only one ophthalmologist in the country who knows how to do it. It's a Belgian ophthalmologist, Dr. Piet Noé. And when I'm there, I know how to do it, and nobody else knows how to do it. So you can use on the machine to do it, but like I said, nobody ever checks if the machine is still working right, so it's a little bit difficult. When I was there, one of my first times in Rwanda, I was working in an eye hospital, and every time I saw the file, it said VA child, and VA is visual acuity, so how much somebody can see, and it said child. So I said, why does it say child? Yeah, we don't know how to examine a child. I said, why? They know the E chart, you can do numbers. No, we don't know. I said, you know what? Send me all the children. I don't care what they're complaining about. Let me just check. So 2 brothers came in, and they were 5 and 7 years old. And they were already in the hospital for 3 years, a patient complaining of scratching, itching, redness, which most people complain about. And it's an inflammation of the eye. And every time in their file, it said VA child. So I said, and it was a pretty rich family. They spoke English, which was lucky for me. And I said to the dad, let me check how much they can see. No, the father said, we just need the drops. I said, well, you're here, let me just check. So the only thing the boys could see was when I was standing 1 meter from them, 2 meters, holding up my fingers and asking them how many fingers I was holding up. So I said, let me check. The boy who was 5 had -7. The boy who was 7 had -9. I'm -9. If I take off my glasses, here my hand is already blurry. So I said, how is school? Yeah, they're not doing so well in school. Luckily, I took the trial frame, put the lens in, put it on the face of the boy, and he was like this. And then I thought, this is the first time he can see. And these boys were already in hospital for 3 years, but nobody ever checked them. And luckily, the hospital had an optical shop, so about an hour later, they came back with their glasses showing, and so proudly and happy and pointing at things, look, and they could see. And then I thought, this is why I'm here. Because those boys never got checked otherwise. And the Belgian ophthalmologist is the sweetest, most gentle man I know. And the next morning at the staff meeting, I never go there, it's in French, my French is not that good. He was so angry that nobody ever checked those boys. And after, the whole staff came to me, please, how do we examine children? So I was teaching them. And I said, if I ever come back to this hospital, which I did, I never want to see VA child in the file again. And luckily, every time I came back, there was no VA child in the file anymore. And that's why also when I try to go to Rwanda every year, I also teach at the university about how to examine a child. For example, if you examine them, for adults you can ask them, cover your one eye. But if you do it for children, they will do like this. So basic things like that. The next slide, school for the blind. There are 2 schools for the blind. One is run by Polish nuns. Some children are in the school for the blind, but are not blind, they just need glasses. But there's no screening, so nobody checked. Next slide has a disturbing photo. If you don't like to see something not very nice, here's your warning. The one left on the down is a boy who came in like this. This is the problem in Rwanda. They come in very late. This boy died a few days after this photo was taken because of the tumor. This one on top here is a boy. This is one day after his cataract surgery, and this was the first time seeing light. So we can still, this is actually the ophthalmologist, so we can still change lives with surgery, glasses. But yeah, this one is born without eyes, actually. You see some children with albinism. Of course, like everywhere in the world. These are photos from the School for the Blind. The right photo down on the right, I made at an orphanage. I was screening at an orphanage, and there were 2 brothers with albinism. Nobody ever checked their eyes, and they now have glasses, so that's good. For 17 days, this is a few years ago, I just made a list about what patients my patients were complaining about. And almost half were complaining about an inflammation of the eye, itching, scratching, redness, tearing. That's what they come in for. And only this little bit, 16 out of 365 become because of blurry vision. Because if you see blurry your whole life, like these 2 brothers, you don't know that you can see clearly, because you think, oh, the way I see is how everybody sees. So they come in very late, like with a big tumor. They come in when they had a knife in their eye, and they come in 2 weeks later because they have saved money for transport, for consultation. You see, a big group here came complaining of strabismus. That is biased, because when I go to Rwanda, they announce on the radio, oh, somebody is coming, and if your eyes are not straight, come to the eye hospital. That's why there's a big group. But normally, there are not that many strabismus. This is actually the girl from the first photo. So now she's straight. So if we look to the future, can Rwanda has screening? Well, let's first answer some other question. Herb sent me some questions about this, actually. Can you use schools? Well, in the capital or in the big cities, most children are in school, but they're only in school when the parents can pay for the school fees. Especially in the countryside, when the people, like I said, earn around €1 a day, children have to help fetch water, watch the goats, cut the grass, whatever. So most of the time they're not in school unless they're enrolled in an organization like Compassion, who's doing a lot of work there. So you can get quite a good amount. Most children in Rwanda do get vaccinated. When they're born, they immediately are scheduled for their vaccination, but that's only for the first year. You can do some basic eye screening in that first year. Who can do screening? There's no orthoptist in the country, there's no optometrist, so the only people we have, like I said, are the ophthalmic clinic officers. They have optometrist kind of people who can screen, but like I said, don't really know how to screen the children. And you only have around 50 in the whole country. How are you going to screen them when there is very limited materials? Where are you going to send them to if they do need a referral? Are you going to send them to the eye hospital? Okay, good, but who's going to examine them at the eye hospital? Is it the only 20 ophthalmologists we have in the whole country? And how are they going there? If people have to pay, for example, if they're deep in the countryside, public transport for us, it's cheap. If you go on a bus for 2.5 hours, it's about €2. But if you have to pay €2 for yourself, €2 for your child, you have to pay for your consultation. Most of the time you arrive at the hospital, you have to wait the whole day. Then you end up, you have to sleep there, which is arranged at the hospitals, but you have to pay to sleep, to eat. Next day you have to travel back. So who's going to pay for all that? I don't know if people are really willing to pay for that. This is pretty bad, but if a white person says you have to go there, they will go. but he also always worrying about money. Who can prescribe glasses? Like I said, not many people know retinoscopy. Where are they going to buy the glasses? Who's going to pay for the glasses? So there's still many questions to be answered. So can we do eye screening? I think so, but not very soon. Thank you very much. Mora Kosichane.
Thank you very much. Is there some urgent question?
Yeah.
Yes, one question from Lisa.
Thank you for that most interesting talk and also wonderful work. In the manual, if I remember correctly, one of the first things it says is that you have to consider what are the things, what are the other concerns in the country. And if one would institute, I would think that if one would institute screening in a place like Rwanda, one would have to think very seriously about what one wanted to screen for. And the first thing, I mean, a question or a comment is, you know, trying to prevent the causes of severe blindness, and identifying cataract and visual. Those are things that can be done under the, perhaps not by professional eye caretakers, but the people who are doing the immunizations and can do that for the newborn babies and then find a way to refer them, and decide, having some sort of think tank about thinking what one wants to screen for before one goes on for what are more luxury items, I would say.
No, true. Yeah.
Thank you. Are you saying something? Because I think we are behind if we should break with the video.
Quick question. Lieke, this is, of course, fantastic work, huh? But in some way it should be incorporated in the preventive healthcare. What do you see any solution? How can the refraction be carried out in Rwanda? Or should we first listen to the next talk about the system they are now adopting in India? Would that be a good idea? Then we come back to this question. Okay, good.
Fine by me.
Yeah. Okay.
I've already announced we are behind the time schedule. And what we will do is that we will forget about the round table, about the manual at the end of the next session. Because there are not so many people here who have written the manual, and we can say a few words about the manual, but we don't have enough people to do the full round table meeting. And then we will first have the last talk of this session, and then we have a 15 minutes coffee break, and then we continue with the last session of the
So Herb, just a suggestion, if you have the coffee break, it's 20 minutes video, and we are very behind. Don't you think we could have the coffee break now?
We have the video now, because it's the same topic, and then we go to the,
Okay.
Greetings. I have an elaborate title. National Vision Screening in India aims at refractive errors at age 9 to 14 years. How much amblyopia would be detected by screening at an earlier age? I thank my co-authors, Eveline and Sarah, for their contributions and support. None of us has any commercial disclosures to make or any conflicts of interest. My heartfelt thanks go to Professor Simons and the EUSCREEN team for their unwavering commitment and support towards providing a meaningful and useful direction of the EUSCREEN cost effectivity model with respect to India. Thank you so much. India is a diverse country of 28 states and 8 union territories with a total area of 3,287 million kilometers square and a population of approximately 1.3 billion as per the 2021 census. The birth rate is 18.2 per thousand population. The death rate is 7.3 per thousand population. The growth rate is approximately 1.1%. All this is 2020 data. 25 to 26% of the population is under 14 years of age. 26.6% of 1.3 billion people is approximately 363 million children in the 0 to 14 year age group. This comes to about 26 million children per birth year. When we extrapolate this data to the approximate population of children in the 9 to 14 years age group, we are talking of approximately 130 million children. Before I proceed further, I would like to appraise the audience of the national programs related to vision in India. In 1956, the first such program was the National Trachoma Program, which was 100% centrally funded. Trachoma was one of the most common causes of blindness then. In 1976, the scope of this program was expanded to incorporate other common causes of preventable and curable blindness like cataract, glaucoma, corneal blindness, retinal blindness, nutritional blindness, etc. And the program nomenclature was changed to National Program for Control of Blindness, or in short, NPCB. In 2001, the NPCB adopted the World Health Organization policy of Right to Sight, or Vision 2020, and the aim was to decrease the prevalence of blindness in India from 1% at that point of time to 0.3% by 2020. This is the first time that the focus was on childhood blindness and refractive errors in a national policy. Thus, the national priorities have been changing depending upon the prevalence of any particular cause of preventable or curable blindness in the country from time to time. Till 2014, this program was completely funded by the center. However, after 2014, the funding was now divided between the center and the states in a ratio of 60:40 and 80:20 in difficult terrains. Also, the nomenclature was again modified to include visual impairment. Till now, the program had focused only on blindness. Now it also incorporated visual impairment as a goal, and the program was called NPCB-VI, incorporating visual impairment as VI. Initiation of the vision screening program in school children with respect to refractive errors was a part of this policy, which was to have rolled out in 2020. I would also like to provide an overview of the vision healthcare delivery system in India under the NPCB-VI. There is an Apex Center at the Dr. R.P. Center for Ophthalmic Sciences at the All India Institute of Medical Sciences, New Delhi, India. Then there are 18 regional institutes of ophthalmology, which are upgraded ophthalmic institutions of excellence associated with teaching institutions. These have a huge catchment area to provide primary and referral services. In addition to this, in parallel, there are 541 medical colleges with their own departments of ophthalmology, 734 district hospitals with an eye department, and a plethora of private hospitals and institutions, some of which you may be familiar with, like the Shankar Nethralaya or the Arvind Group or the LV Prasad Group of hospitals. The community outreach programs of these private institutions are substantially funded by the NPCB-VI. Coming to the rural network, one village in India comprises a population of 1,000 people. 5 such villages, that is approximately 5,000 people, are catered to by a medical sub-center, which at present does not provide ophthalmic services. 6 such sub-centers comprise what is called a primary health center under the aegis of one medical officer. That is, a PHC caters to about 30,000 people. There are about 24,000 PHCs in the rural network and 6,000 in the urban network currently. Since 2014, an ophthalmic assistant is being mandated at this level. 4 such PSCs comprise what is called a community health center. These are usually 20 to 30 bedded hospitals catering to a population of about 1.2 million people. This was the level at which an ophthalmic assistant and an optometrist was present. However, as I mentioned, that an ophthalmic assistant is now being mandated at the level of the PHC also. The ophthalmologist comes into the picture only at the level of the district hospital, which is also the level at which ophthalmic surgery starts. Here, I would also like to draw your kind attention to the school eye screening programs, which became a part of the NPCB since 1994. Pretty much of the design, concept and infrastructure of the National Vision Screening Program in School Children 2020 is based on this preliminary program. I would like to mention that primary education in the age group of 6 to 14 years is mandatory in India, and as per 2016 data, there are 840,000 such schools catering to primary education in India. Coming to the National Vision Screening Program 2020, the school eye screening by trained teachers has been the largest group catered to under NPCB after cataract. It was planned to prioritize this program in a more collated way under the aegis of the Vision 2020 policy to provide homogeneous screening services throughout the country. This is the policy booklet that is available free over the internet. I have copied the link also for the reference of the audience. Based on administrative, logistics, social and medical reasons, the student age group of 9 to 14 years was selected for greater reliability of results of testing, students understanding the purpose and need of the testing and who also acted as social messengers, and also to screen for myopia in the prepubertal adolescent age group. Myopia has almost been an epidemic in the East Asian countries recently. While this is not entirely true for the South Asian population, it was considered appropriate to screen for myopia in the prepubertal adolescent age group, where an increase in axial myopia is characteristically seen with the generalized adolescent growth spurt. With this background, I will now talk of the application of the EUSCREEN cost effectivity model for early amblyopia screening in India. Based on the Indian National Sample Survey 2014, the number of children in the 6 to 13 years age group is approximately 204 million. The total number of children out of school are about 6 million. So the total number of school children in the age group of 6 to 13 years is approximately 198 million. Averaging this out, the total number of children per birth year is therefore approximately 28 million. This data can be extrapolated to the 9 to 14 years cohort specified for the school vision screening program, that is approximately 141 million children. Now we come to the cost effectivity assumptions. If we assume that at first 20% of the targeted population of school children in one birth year, which we already mentioned was about 28 million, is screened, the total number of school children to be screened is about 5.6 million children. Of these 5.6 million children, we can reasonably assume that 10% are already under good ophthalmic care, wear glasses, etc. and don't require further screening under this program. This makes up for a population of approximately 5,040,000 children who will require screening under this program. The estimated budget for this program as in 2020 was approximately 78 million Indian rupees, which I'll be referring to as INR from now on, which is equivalent to about 886,000 euros at the current conversion rate of 1 euro to 88 INR. In direct calculations, this means that one screen test, if we divide 78 million INR by the population of 5,040,000 children, to be about 15.4 INR or about 0.17 euros. There is another way to cross-check this calculation. The identified personnel to conduct the screening are school teachers with a salary of INR 29,166 per month or about 331.4 euros as per current conversion rates. At a 40-hour per week work schedule, the total working hours are thus about 168 hours per month. Assuming the screening evaluation to take about 3 minutes or 0.05 hours on an average, the manpower salary cost per screening test is about INR 29,166 divided by 168 into 0.05, that is approximately INR 8.68 or 0.1 euros per screen test. As mentioned previously, as this program has already been in effect since 1994 with an infrastructure and network support that is already present, we can assume a 50% recurring overhead cost for the actual screening to take place. This works out to be approximately 7.73 INR or 0.08 euros. Thus, one screen test would cost approximately 16.41 INR or 0.18 euros, which is similar to the more simplistic calculation shown in the previous slide. Insofar as the School Screening Eye Program 2020 in India is concerned, we can stop over here at the cost per screen test. However, applying the EUSCREEN model for further health interventions and management in this cohort, if we assume that 10% of the screen subjects will be sent for diagnostic evaluation of the refractive error in focus, that is myopia or amblyopia, this comprises a cohort of 504,000 children per birth year. Evaluation of these children by trained optometrists at a salary of INR 31,416 per month or 357 euros at current conversion rates, again with a working schedule of 168 hours per month and an evaluation time of about 15 minutes, that is 0.25 hours per child. The manpower salary cost per diagnostic evaluation comes out to be INR 46.75 or 0.53 euros per child. Thus, the total cost of the diagnostic evaluation for 504,000 children would be about 23.5 million INR or 267,750 euros at current conversion rates. The prevalence of amblyopia varies between 2 to 5% globally. Assuming a prevalence of 3.5% of the subjects referred for the diagnostic evaluation, that is N is equal to 504,000 children, about 17,640 children are expected to have amblyopia in this cohort. Assuming that 25% of these subjects would receive management from other sources, about 13,230 patients are expected to be treated under this program. Taking the costs for optometry services to be the same as what has been elucidated in the previous slide, excepting that the duration for amblyopia management services would be about 27 minutes for the optometrist, the cost per child comes out to be INR 84.15 or 0.95 euros as per current conversion rates. In addition, ophthalmic assistants would also play a nominal role in vision assessment in these children. Estimating a 3-minute evaluation per child, the total costs for the ophthalmic assistance services would be INR 4.29 or 0.05 euros per child. Thus, the total duration of time for amblyopia management services by the optometrist and the ophthalmic assistant would be 27 plus 3 minutes is equal to 30 minutes per child. Also, thus, the total manpower cost of providing treatment to a child with amblyopia is INR 84.15 plus INR 4.29 is equal to INR 88.44 per child. That is approximately €1 at current conversion rates. The average cost of glasses is INR 500 or 5.6 euros. Thus, the total cost of prescribing treatment in glasses per child is INR 88.44 plus INR 500, that is INR 588.44 or approximately 6.6 euros. The total cost of providing amblyopia treatment to 13,230 subjects is therefore 7.7 million INR or about 87,318 euros as per current conversion rates. Now, 75% subjects would respond to refractive adaptation or glasses only. Patching may be required in the remaining 25% cases. We have an improvisation for patching. A 2-inch micropore adhesive is cut in the shape of a patch and an appropriate paper patch of a smaller size is pasted on its adhesive side, thus simulating the look of a commercial patch. This is extremely economical as a micropore can last for months. So the costs of this is not being calculated here. We have provided additional costs for the first preliminary management protocol for amblyopia. The anticipated cost for follow-up evaluation will be less because of lesser time required by the manpower, that is the ophthalmic assistant and the optometrist, as well as the fact that the glasses need to be changed if required only after 12 months. Thus, in synopsis, we estimated that the cost of vision screening in children as per the School Eye Screening Program 2020 in one birth year is about 16 INR per child. costs for diagnostic evaluation for myopia and amblyopia would add about 22.5 million per birth year to the costs of this screening program. Further, costs for amblyopia management would add about 7.7 million INR per birth year to the costs of this existing program. Hence, the costs for diagnostic evaluation for amblyopia and its further management in one birth year is INR 31.3 million. This can be added to the sanctioned costs of INR 78 million for visual screening, which is already present. This would be a total of about 109.3 million INR, or about 1.2 million euros. This additional cost of INR 31 million per birth year for diagnosis and management of amblyopia can be added to the cost of the existing program from 9 to 14 years of age. Now, screening for amblyopia at 9 years can be a bit late in terms of further management, as visual plasticity decreases with increasing age. The average compulsory age of admission to primary school in India is 5 years in 14 of 28 states and 5 of 8 union territories, and 6 years in 12 of 28 states and 3 of 8 union territories. The national compulsory age for primary school admission is, however, 6 years. If we incorporate inclusion of 20% of the number of school children at 6 years of age, which is 5.6 million children, and further deduct 10% of those who will not require screening, and apply the fact that 3.5% of this cohort is expected to have amblyopia, we are dealing with a population cohort of 176,400 amblyopic children. 75% of these children with amblyopia would respond to glasses, which makes it a cohort of 132,300 children. Extrapolating the costs of screening, diagnosis and management, including glasses per child for amblyopia, would thus be INR 16 plus 47 plus 588 as per what we have already estimated and shown in the previous slides. This would be equivalent to INR 651, or about 7.3 euros. Therefore, the total cost for screening, diagnosis and management of 132,300 children would be about 86 million INR, or approximately 1 million euros in one birth year. This program can be separately started at 5 to 6 years of age as an amblyopia specific screening, diagnosis and management protocol. Thus, if we add visual screening for amblyopia with its diagnosis and management at 6 years of age to the existing School Eye Screening Program 2020, we add costs of approximately INR 86 million per year, approximately 1 million euros per year for 3 years from 6 to 9 years. In case we want to start this amblyopia screening, diagnosis and management program at 5 years, it would entail an additional cost of INR 86 million per year. After 9 years of age, an additional cost of INR 31.3 million, or about 356,000 euros, can be added to the existing sanctioned costs for the School Eye Screening Program 2020 for children from 9 to 14 years of age. This would indeed be an effective and extremely useful addendum to an existing school eye screening program and a meaningful application of the EUSCREEN cost effectivity model for early amblyopia screening, diagnosis and management to the benefit of millions of children in India. Thank you so much for a patient hearing.
Thank you, Sia Chowdhury. Is there a question? Herb?
Zia, this is really a, what would you say, a torrent of figures. So it clearly demonstrates that people from India are very good at mathematics, but also Evelyn is very good at mathematics. But to summarize it, it means that if you increase the current program that screens for myopia and other refractive errors at the age between 9 and 14, if you let that start at 6 years of age, it is how much was it? 15% more expensive? Maybe you should chat the answer because we don't hear the sound.
Oh, okay.
Oh, now we hear you. Now, chat us the figure because we don't hear the sound.
Yes, can you hear me now, Dr.
Yes.
Simon? Okay. Now, yes, approximately it would add about 50% more to the cost. For 5 years, we have 3 years, which would be about €1 million each if you start at 6 years, 7 years, 8 years. And from 9 to 14 years, we are adding about, say, €0.3 million or something like that, so €30,000. So that, let's say, about €1.5 million and €4.5 million to something that is already about €4.5 million.
Excellent. So you're now writing a paper about this with Evelina.
Yes, because this has really come out very well. I thank Evelina for that, but I took a long time because the calculations had to be done properly. I wanted to give an accurate representation here. So I could only send you the presentation by Sunday. I'm so sorry about that. Thank you.
So now we have coffee break. Thank you very much, Thea.
Thank you.
Bye. Thank you so much, Dr. Shimons. Thank you.
Yes. Good morning, everyone. My name is Harry Koning. I'm Deputy Head of the Department of Public Health and have been responsible with a team of people on the modeling for hearing and vision screening. In this session, we're going to talk about the conditions for implementation. We will have a talk first from Evelien Heijsdijk on the model, and then two video and a talk by Jan Kik, and two videos from the UK, who of course unfortunately couldn't travel. So Evelien, would like to start with what we did with the modeling? Thank you.
Yes, I will tell something about the development of the model. You can all use this model in the web tool. I will explain more about the background of this model. So the aim is to evaluate the benefits, the harms, and the cost effectiveness of the current screening program.
Ietsje omhoog. Ietsje omhoog. Ja. Ja, dat is goed. Ja, dat is goed.
Current screening vision and
we moeten niks,
program,
kunnen
and
het
to
wel
predict
doen.
the effects of the introduction of the change of the program. So the model is a micro-simulation model, and it means that it simulates a large cohort of people. So for example, this is for the vision screen, so when you simulate a number of people, and 50% get amblyopia, then the model readily picks out persons.
Oh, sorry. Is het harder? Is het harder of voor helemaal niet?
Yeah. You can simulate a large cohort of people, and when you have a 3% prevalence of amblyopia, then the model randomly picks 3 people who will develop amblyopia. And this also works for the other parameters in the model. So also who gets the screen test, who will test positive, who will be treated successfully. So that's all based on probabilities we have as an input, and then a model randomly picks out those persons. So we use the following steps in modeling. First, we have to develop a model structure. Then we have to calibrate the unknown parameters, and we usually do this to large studies with a lot of data. Then we apply the model to different settings, for example by populating the model with a different population or a different screening protocol. And then we can calculate the cost effectiveness. So I will first show something about the vision model. We use this list of parameters, so the prevalence of amblyopia by age, the amblyopia type, when and how many times it is detected by parents, the test characteristics by age, and diagnostics, treatment, and cost and quality of life. So we calibrated our model on the OVAS study, the study that Herb explained yesterday, as the disinvestment study. So in this study, all screen moments between the age of 6 to 16 months were evaluated, and it was evaluated whether the amblyopia was detected by parents or by screening. In the control arm, the children had the regular screening protocol at that moment, with a lot of screens under the age of 36 months. And in the intervention arm, there were only screens above age of 36 months, unless there were reasons to screen. So here you see the number of children detected with amblyopia by age. The solid line is the cumulative number in the study, and the dashed lines is the model prediction. So after we estimated the parameters, so you can see that the model predictions are close to the observed values. And also when we look at the number screen detected or detected by the parents and by type of amblyopia, you can see that the model predictions are quite close. So this is the observed data on the left, and on the right is the model predictions. Then we didn't change any of the parameters in the model, except for the number of children and the screening protocol, to simulate the intervention arm, so the arm with less screens. And here you can see again that the model predictions are quite close to the observed values, also for the type of amblyopia. So now we have a model for the detection of amblyopia, but we also have to model the consequences of that. For the treatment success, we assumed that children can be successfully treated until age 5.5, and successfully means that about 75% of the children will be treated successfully. Then the treatment success declines until age 12. So this is an assumption, but based on literature. And for the quality of life, we made the assumption that when you have persistent amblyopia, so unsuccessfully treated or too late detected amblyopia, that you have a unilateral vision loss for the remaining lifetime, so a very long period. We assumed a vision loss of 1%, utility loss of 1%. There's only one study. In that study, 3% was found, but we think that's a little bit high. It was asked to very young people, so that can be the reason. So we assumed 1%. For bilateral vision loss, we assumed 8% based on the study of Van der Graaf in the last 7 months of life, which is a study of Van Leeuwen. So people with persistent amblyopia have unilateral vision loss, and in the last 7 months, bilateral vision loss. So here are some model results. So if you have no screening and you screen and you have follow 1,000 children, then you will have about 35 cases of amblyopia detected. And the black triangles is the number of persistent amblyopia. So about half you cannot treat successfully. If you screen at age 3 years, so the next bar, then the orange bar is the number of screen-detected cases. You see that there are less persistent cases of amblyopia. So with screening at 4 and 5 years, there are even a little bit less. And at 6 years, a little bit more, because then for some cases the treatment is too late. And if you have multiple screens, so for example at age 3 and 4 years, you can see that you have a little bit less persistent amblyopia, but the difference is not so big anymore. So we can also add the cost and the qualies. So on the x-axis the costs, and there the qualies for each protocol, so each dot is one protocol. And you can see if you do one screen, that the screen at age 5 is the most cost effective with this set of parameters. Because you have the less cost and the highest qualities gained. So the strategies on this line are the best strategies. We can also compare the current screening protocol in the Netherlands. It's the gray square. And we can compare that with a former screening program with multiple screens below age 36 months, which is the black square. So you can see with the current screening program you gain a little bit less QALYs, but the costs are about halved, so it's much more cost effective. So of course the results depend on the parameters, so we also varied some of the parameters. And you can see that, for example, the treatment success has a large effect on the results, but the most effect has the utility assumption for the unilateral vision loss. So we assumed 1% in quality of life. But if you assume 2% or 0.5%, well, that really changes the results a lot. So and you can try this model in the EUSCREEN web tool, which we will explain this afternoon. Then something about the hearing model. So the structure is kind of the same, but of course there are some things specific for hearing. So that is that there are 2 tests, and the sensitivity and specificity depend on the day of testing. And you can have multiple rounds. So we talked yesterday about the importance of the loss to follow up between each round. So we did this for Albania. We had our model and we simulated some different protocols. And we assumed that children stay in the hospital for 2 days. So if you do a test on day 1 or day 2, then you have a high attendance of 95%. If you have a test, for example, on day 10 or day 30, then the children have to come back and you have a lower attendance. So we assumed here 70%. And then you can see the cases detected, which maybe this is a nice example, the AABR. If you do 1 time AABR, the last bar, then you will detect a lot of children because you do only 1 test and then you refer them for diagnostic assessment if the test is positive. But if you do 2 tests and they have to come back to the hospital, then you detect much less because only 70% returns, so you miss a lot of children. But if you also take the referral rate into the referrals into account, so now the orange bars are the cases detected, so the previous graph, but the blue bars are the cases referred. And you can see that if you only do 1 AABR, then you need to refer a lot of children. And when you do 2 AABRs, then you need to refer much less. So what is optimal for a country or for a region even? It depends on how many children are coming back, and of course of the cost of screening in relation to the cost of diagnostics. Whether you want to have this bar or this bar more important or the other bar. And also this you can try yourself in the EUSCREEN model by filling out some different protocols. So for example, this is one of the results of the models. So 1 AABR versus 2 AABRs. So you can see you need more tests, of course, but you have less referrals to diagnostic examination when you do 2 AABRs. And the total costs are less than doing 1 AABR in the end. So, but of course you can try this yourself in the program. Thank you.
Thank you very, very much. Questions from the floor. Was it relatively clear cut? That is the intention. Thanks. Do we have questions from the chats? Or, so again, what Evelyn is talking about here now in 15 minutes has been hard work in the last 4 years with the whole EUSCREEN team, of course. But you can see it really helps you in making some comparisons, and surely the truth is probably somewhere in between, because many times you don't know the exact details, but nevertheless it gives you a good estimate of what you're doing with your program, and that you have to include all the referrals, costs, quality of life to get a final estimate on what you're doing. So thank you very much. Question. I'll check who is next.
Thank you, Evelyn. For the vision screening, I saw a chart with all the errors and the effect of the errors, if I remember correctly. Is there such a chart also available for the hearing screening? What do you think are the most important influences which are uncertain for now?
You could make it yourself.
Yeah, I remember in the paper we did also some sensitivity analysis. I think the cost of diagnostics was very important, and the follow-up. Yeah, I think those two are the most important ones.
Good, thank you very much. Yep. So we go on then with and onwards about the cost of vision screening, cost of treatment on video. Let's see.
Hello again. Today I'm going to be talking about costs. And I'm going to be using two local services, one of which is the Reading service, as examples. And in the UK, there is a common recommendation by the National Screening Committee which suggests that orthoptists should lead or deliver screening services in the first year of compulsory education using a single visual acuity test and a gross external examination. And all costs of all treatment and screening are state funded. The service in Reading, where I come from, has existed for more than 30 years, well accepted, well embedded. It uses orthoptists as testers, and we will test easily 70 children in a morning. Children wearing glasses already are not screened, and borderline referrals are recalled in the next school term. Screening and treatment services are very well integrated, and the screeners know the outcomes of the patients that they refer. And it's well audited with regular small changes to improve efficiency. And because it's a National Health Service, there are incentives to make this as efficient and cheap as possible. The neighbouring town has only had a service since 2013, and it's administered by school nurses paid for by the education services, and it's an addition to their current jobs, so it's done with other health checks. There is no retest option for borderline referrals, and the just fails are referred to local opticians and lost to follow-up. There's little contact between the screening and treatment services, so audit and feedback is really difficult. But they're doing the same tests at the same age in school, and the demographic mix in the areas is very similar, and all referrals come into the same hospital trusts, so we know what happens to all of these children because there aren't any alternative treatment centres. So we see about 5,500 children in each area, fairly similar numbers are referred. We lose some of the data from children that we don't know how many go to the opticians. And the follow-up, long-term follow-up, is really very good. We find out what happens to 75% of these children. So of those followed to diagnosis, we've got much better figures for the orthoptist-led service, very high true positive rates, low false positive rates compared with the school nurse service. And where we've got the data, we could work out the sensitivity and specificity and positive predictive value, which is much better from the orthoptist-led service, orthoptist-run service. If we talk about the outcomes, most of them are given glasses. We've lost some of the data for the school nurse service. And of those, most of them come up just with glasses alone. So only 25–28% still have amblyopia when they come back with their glasses, and some of them, about just under half, will improve just with glasses with no occlusion. Some of them still have a little bit of residual amblyopia, some of them are still having treatment, but in fact only one child has visual acuity less than 0.4 logmar in their worst eye, and all have really good vision in their better eye. The median number of visits for all children is 3, and the median number for amblyopic children is 5. If we look at the costs, each screen cost about £4.20, about €5. The cost of the false positives, though, was much higher from the school nurse service because they had taken up expensive hospital appointments, and so that inflated the cost per amblyope treated. So we're getting excellent outcomes for referral. There are a few very mild amblyopes and only one significant amblyope. False referrals are very expensive, and if there are false positives, there are probably some false negatives being missed. Orthoptists are much better at testing vision than school nurses, but yes, it's to do with training, experience and feedback. It isn't necessarily to do with the job title of the person, it's just that they know what's going on and they get a lot of practice. And we found that very small changes from careful audit can improve efficiency dramatically. The drivers of the screening costs are the things that you can put into the EUSCREEN model, things like sensitivity, specificity of tests, age, availability of screeners, number of children testable, and the cost of workup. But I'm now going to talk about post-referral costs, and these are much more country-specific, and different countries have different healthcare models, and what screening you choose depends on the post-referral case mix. And also you need to take into account public acceptability and uptake. And it depends on what's motivating the decision makers. Is it a public health aim, perfect vision, good to a certain level? Is the priority to minimise burden on already stretched services? Is there a profit motive? Are people wanting to make money out of an extra billable extra, more referrals, more profit? Or what will insurers reimburse? The referral mix will depend on the choices that people make. And now I'm going to be talking about the referral mix per 1,000 children screened. And 5 different screening options that are commonly used, so a single or a repeated photo screen, 2 different age visual acuity screens, or a 5-year-old super duper photo screen and visual acuity screen. And the case mix will vary. From all of these, you'll get a certain number of false positives, some simple refractive errors, some will just improve gradually with glasses alone, and then there's marginal, mild and dense amblyopes which need more intensive treatment. The referral rates will vary, and these are fairly common types of referral rates from the different types of screening, and so you'll get very different numbers of children coming in from your screening. And depending on what's going on, so for instance, photo screening will refer a lot of refractive errors, but there won't be quite so many amblyopes as there is with the visual acuity screening. Now I'm moving on to per 100 children that are coming into a service. So this is, if you're going to have 100 referrals, how do you cost how much they're going to cost? So this isn't cost per children screened, it's per referrals. Using the case mix, who's treating the children, how often they're seen, and all of these variables. Mainly the number of visits, it's not the cost of glasses or atropine, for instance. This is going to be a very busy slide. Don't particularly concentrate on the big numbers. There's going to be a take-home figure at the bottom in a minute. But we're basically looking at the proportion of different types of referrals. So this is an orthoptist visual acuity screening at 5, managed by the orthoptist throughout the treatment. So these are the Reading figures. Some conditions take longer to treat, so some children will be a bit older when they're discharged. And so some conditions will take many more visits than others. So dense amblyopia will be treated will need more visits. Then you can put in these variables: duration of occlusion, how often they're refracted, how much glasses cost, and who is seeing them. So the bottom line here is this figure down at the bottom. So for this orthoptist managed visual acuity screening, the baseline cost is 61,000 euros. If we change this and we make the screeners a little bit less expert, so there are more false positives and possibly more false negatives, it's a little bit cheaper. That bottom figure is a little bit cheaper than that 61,000. But what's happening is that some children are probably being missed, and false positives annoy everybody. They annoy parents and they annoy ophthalmologists. If we just tweak things, so if we make the person treating the child an ophthalmologist and we give the child one more visit per journey, you've more than doubled the cost very, very quickly. If we look at photo screening at 3.5, the case mix will be very different because the children are seen younger and so refractive errors are picked up, but fewer amblyopes, we hope. But because they're in the system longer, each child will need more visits. And so that bottom line figure has increased quite a lot. And remember, twice as many children will come in from an early photo screen than from a later visual acuity screening. So these figures are per 100 children. And the prevalence of amblyopia is only going to be reduced if the children are carrying out the treatment that they've been offered. If you do one more visit per child, all of a sudden the costs are going up again a lot more. And if an ophthalmologist is the person who's doing the treatment, the costs become considerably more than if an orthoptist is doing it from a different type of screening. So from 6,000 children screened, for example, the model says about 233 will come in, and the total cost of that is those figures, 142 to 349,000 euros. If you do photo screening for the same 6,000 children but a little bit earlier, you will get many more referrals. And the potential for the costs is suddenly multiplied up a lot. And these are the figures because these children may be seen by somebody more expensive, but they're particularly seen more frequently. So the potential is something like 8 times as much. There are also soft costs and benefits. What about the cost of parental earnings and distress and stigma and failed appointments still cost services? And what about the benefits that nobody's really looking at the moment? Costs is not the same as cost effectiveness, and cost effectiveness isn't so much what it costs, is it worth it? And do the marginally better outcomes from earlier detection justify greatly increased costs? And are the harms that outweigh these benefits? So the take-home message is photo screening potentially is a lot more expensive. Small differences change things dramatically, and you need to think about what your country generally does. And so the screening decisions you make may depend on what you're able to provide or pay for later. Will they access the treatment, for instance? And maybe should we be thinking that investment should be going into better audit, better training, and perhaps later screening and public health education rather than very expensive kit? Thank you very much.
Thank you very, very much.
I'm doing something on the... Yeah, good. Questions from the floor on this? And yeah, that's good, I know. That's very good. Are there questions from the chats or not? No. Thanks very much, Anne. I do have a question. In the beginning, you nicely showed huge differences in the cost for false positives between the two, well, let's say regions or programs. And it seemed you were surprised a little bit yourself. What was the reason for that?
I think it's definitely the expertise of the screeners, and I'm not casting aspersions on the school nurses, but I think they aren't as well trained, but particularly they don't find out what happens to their referrals. They're not committed to the service in the same way. If I see a child in the hospital who has missed in screening, which is very rare, I go and find out if they passed.
Yeah.
I know how well they've done. We know, each orthoptist in the area that I work, we know how good we are. And we know, you know, that there are some people, if somebody's false referral rate has gone up a little bit, somebody just tells them that it's happening. So we do audit really tightly. And because it's the National Health Service in the UK, there are pressures for saving costs all the way through. So if we can save a visit for a child, you know, it's these tiny adjustments, tiny changes to audit and really close monitoring the data that seems to be making the difference between these two services. And, you know, this does seem to be a super efficient way. And we've spent a lot of time paring down to what seems to be the minimum to get an acceptable outcome.
Yes, thanks very much. Other questions? So would this be a one-time that you did all those costing and repeat that in 5 years' time, you think, or how does it work?
We do it, we keep a rolling audit all the time. For this, I did work out the costs based on that year's published national costs, but it could be done every year. It's just that we don't do it every year, but we do audit the outcomes regularly. The school nurse service probably doesn't, and that may be one of the differences. We keep a rolling audit and they don't.
Yeah, thank you very much. Feedback always important. Thank you very much. We go on with Jan Kik, who did a tremendous job in trying to come up with which data do we need actually to come up with cost-effective programs. So Jan, yes. The floor is yours.
Thank you.
I should not do that.
Yes, I will be talking about the current monitoring in the pediatric vision and hearing screening programs in Europe, and about what we would need to be able to do comparative cross-border cost-effectiveness analysis. The background is that, as we all know, there is a substantial diversity in pediatric vision and hearing screening programs in Europe when it comes to the age when children are screened, the tests that are used, the different professions that perform screening, and the way screening programs are funded. All these differences make it very difficult, if not impossible, to perform comparative cost-effectiveness analysis. In the EUSCREEN study, we developed a model specifically to this end to compare cost-effectiveness of programs, as Evelien presented just now. And to populate the model with data, because we of course need data to be able to run the model, we conducted within the EUSCREEN study a survey that was a very extensive survey that was filled out by screening experts from 45 countries. The survey was divided in 3 parts, one part on vision screening, one part on hearing screening, and also a part on general screening that we, however, are not using here in this analysis that I will be talking about, because we wanted to focus here on vision and hearing screening. What methods did we use? First, we assessed the current state of monitoring in European vision and hearing screening programs based on questions that were in the EUSCREEN survey. Where the experts were asked about whether there was quality assurance in their programs, whether they published results of their programs, and similar questions. Next, we identified the data that are essential for cost-effectiveness analysis, which we based on the data that we need to run the model. Then we went back to the results of the survey, and we looked at the survey to see how many of these essential data could be provided by the various screening programs in Europe. We limited the analysis of the data to 45 countries in Europe, and several not in Europe, but that do participate in the Horizon 2020 program. We also had additional data from China, India, Malawi, and Rwanda, but we did not include these in this analysis for sake of consistency and comparability. The results of the assessment of the questions on monitoring was quite telling. In vision screening programs, there is only information about the outcome available in 31% of screening programs. It's in hearing screening programs, it's a much larger part that has information available about the outcome, 75%. But of course, you need to realize that this was only that the question that was asked was, is there any information available on the outcome? So if there is information, that doesn't mean anything about the completeness or the quality or the timeliness of the available data. Then we also asked the experts whether there were methods for quality assurance imposed by the government in their countries, and as you can see, that is only the case in very few countries for both vision and hearing screening. We also asked whether cost-effectiveness analysis had been carried out for the vision or hearing screening programs in their countries, and again, this was only the case in very few countries. Another question was whether some kind of research had been carried out into screening programs, and here majorities of both vision and hearing screening experts said yes, some research has been carried out. Some also provided examples of research that had been carried out. When we looked at these examples, we found that these research are often isolated, incidental research projects that are usually cohort-based, often retrospective, and usually very limited in scope. We also asked specifically whether studies on the effectiveness of the screening programs had been carried out, and this was the case in only about a quarter of the vision screening programs and less than half the hearing screening programs. So our preliminary conclusion on the current state of monitoring in vision and hearing screening programs is that in most programs data is not collected in a systematic and continuous manner, and that data are not always accessible or available or complete. This is not to say that no data are recorded. There are examples of programs where data are collected in a systematic manner, such as, for example, the Dutch newborn hearing screening program, which publishes a very detailed report every year detailing all the outcomes of the screening program. This is, however, an exception. But even when data are not published, it doesn't mean that they are not being collected. Data are often collected, as we could see in Anna Horwood's presentation just now, but these data are often collected in regional or even local context, and they may be used, for example, for quality assurance within the local program, but they are not, for example, aggregated on a national level, and they are not accessible or available, and definitely not published. Another thing is that when data are, for example, recorded with the purpose of performing quality assurance, these are not necessarily the exact data you need for cost-effectiveness analysis, which is where we are going to turn to now. We identified the following variables as essential for comparative cost-effectiveness analysis. The prevalence, the age at which children are screened, the screening test that is used, the test threshold that is used, the sensitivity and specificity or referral rate, which as also became clear in the previous two presentations, especially the specificity is very important because false referrals, false positives lead to very expensive, excessive referrals. Then, of course, you need to know the coverage and the attendance, the loss to follow-up, as we have also heard earlier today and yesterday that is very important. And obviously, when you want to perform cost-effectiveness analysis, you need to know what the costs are of a program. So we looked again at our survey data and we analyzed which countries could provide information on several of these key variables. And as you can see, when we looked at the data on prevalence, about almost half the vision screening programs had no data and 19% of the hearing screening programs had no data. That's the red parts are countries with no data at all. The blue parts are countries that had partial data or estimated data. And the green parts are countries that had actual data. And again, we can see, which is kind of consistent throughout this analysis, is that there is more data available on hearing screening than there is on vision screening, which we can see again here in this slide when we look at the data that is available on attendance. And of course, when we look at the data on sensitivity and specificity that are very important, we can see that these are not available in the vast majority of programs. And for the last variable, we will be looking at the data on loss to follow-up. Again, in 3/4 of vision screening programs and 35% of hearing screening programs, there is no data on loss to follow-up, which is also very important when you want to do comparative cost-effectiveness analysis. So, what do we need if we want to perform comparative cross-border cost-effectiveness analysis? We would need a standardized set of these key variables that we have seen that should be collected in all screening programs, and they should be collected in a uniform manner. Because if every program would collect all the necessary data, but they would all record them in a different way, you would still run into a lot of trouble if you would try to compare. So not only the collection itself is important, but also the way in which the data are collected is important, and it has to be done in a uniform manner. Data should be collected digitally for a variety of reasons. Digital data collector is efficient, it minimizes costs and the administrative workload, and in addition it also minimizes errors, and it has options to perform real-time quality assurance, because when you collect these data anyway, because you want to do a comparative cost-effectiveness analysis, it doesn't mean that you can't put these data to other good uses as well when you record them anyway. Since we say the data collection should be done digitally, this should be done with a database, and the database should be accessible to all professionals preferably all professionals in the, not only in the screening program, but in the entire screening, diagnostic, treatment pathway. And the data should be timely, they should be complete, they should be unique, they should be valid, consistent, and accurate. To assure that the data is of good quality, it is very important that all professionals in the screening diagnostic treatment pathway are aware of the importance of monitoring and also of the importance of good quality data. Because when you, for the people who screen or do diagnosis or do treatment, recording data is not their primary job. And when you ask them to do that, they will probably see it as a burden that they really don't feel like doing. But when you tell them why it is important, and they understand why it is important, they are much more likely to perform the data collection in a decent manner. We should also not forget that data collection isn't cheap. It costs money. You need a database, you need time from all the professionals who have to record the data. So when you plan and budget a screening program, you should take into account from the outset that you have to record data, and you should allocate funds for that. And you should also not forget that data collection these days is complicated by the fact that you have to comply with legislation which in the European Union is mostly the General Data Protection Regulation, or GDPR as it is known. Well, that's it for the moment.
Thank you, Jan. Thank you very much. Other questions from the floor, from online?
There's a question from
Yep.
Anna. She forgot to mention something.
She forgot to mention, so we'll do that then in a minute, I think. Questions from the floor? Yes.
Jan, thank you so much. One of the things I forgot to say is that in addition to having the database available to all the people who are involved in the screening, it's probably important to give them feedback as how they're performing related to the regular database. And what we've done every year with the reporting of the aggregate reporting and the hearing screening is that each hospital and director of the hearing screening program in the hospital gets a report on how they're performing related to the rest of the hearing screening program, so they can work on comparing their referrals and their referral rates and their fail rates for after each section of the and coverage, indeed even coverage, so that they can benchmark themselves and work themselves towards improving.
Yes,
and that should be added, I think, to your recommendations.
Yes.
Would suggest that.
Well, I completely agree. That's more or less what I meant when I said that the data that you collect should also be used to put to good use for real-time quality assurance, which of course includes feedback to the screeners on their results.
Thanks, but that would be a good additional recommendation, that with feedback there is then more enthusiasm to go on and see why you're doing differently, sort of. Yeah, please.
Thank you again for the excellent work. Would the group consider to repeat in the future the first questionnaire and evaluate what the progresses have been in the last 4 or 5 years?
Well, it's a very interesting thought. But,
and maybe more important, I think, as we say in Dutch, and then the bridge to the next question, that's wrong English, of course. But so indeed, so we started off with a large questionnaire. You know them. Now we know too large, actually, but still you get a lot of information. I think Jan nicely shows now, actually, if you look at at the red pies or the pies slides, we should at least have a sort of minimum of data for the whole of Europe. And if we get like 10 minimum data, and maybe 10 is too few, but nevertheless, if we get that, would be crucial. So I think you nicely shows, if I may to start, you nicely show the attendance or coverage, the sensitivity, the loss to follow up, and maybe the amount of treatment, and then we can expand on that, of course, but he nicely shows you that if we miss that, you cannot say anything about your program. So, good suggestion. Let's see how we can continue in saying at least a sort of minimum number of parameters to record all over Europe. Yes, please.
Yes, I just want to add that in Sweden now actually have a national register where all different professionals can log into, the speech therapists can log into and put in their data, and the medical doctors, audiologists, everyone that is connected, and for all children that have a hearing loss in the best ear, 30 dB or less, so it's also for unilateral hearing loss. It's been online for several years, but it's now been extended so more people can log into it. But of course, it's still the challenge to have everyone to provide their data. That has, because it's not by law that you have to do it. So that's still the challenge.
Yep. Yep.
So that will be reliable figures in this register.
Yeah.
Yes, but the digital infrastructure is available nowadays. So
yes. Yeah, so this will be a nice next challenge, I think. Thanks.
It's doable at least.
It is really now doable, and surely it was quite difficult in the past, but now, as you say, it is really, really doable. So again, you said that the hearing is one of the examples for the Netherlands where we have some data. I must admit, I started with that 30 years ago, and they only knew attendance rate and referral rate, nothing else. They didn't know how good they were, they didn't know sensitivity, whatever. And so apparently we did make some progress, but it's good, a very good final product of this EUSCREEN. Yeah, I think there were no online questions, but no, but Anne had something to add. So thank you, Jan. I think Anne, you. Yeah, please go.
Thank you. Just a very quick point that Jill Carlton and Helen Griffiths, who've been really involved with this project, have been set up a BIOS regular audit of our results. So this is the British and Irish Orthoptic Society. So we are capturing not such detail, but there is data captured annually across the UK for orthoptic screening services. And they do a great job, or did a great job, and it's now been handed on.
Thanks. Yeah. So indeed, feedback and audit is probably the two additional keys you should write in your paragraph in the paper. Thanks. I think we have now, thank you, one more video from Jill Carlton about acceptability of childhood screening. Yeah, thanks.
Hello everyone, it's a pleasure to be able to talk to you today to present the findings of some of the work that we undertook as part of the EUSCREEN project. My name is Dr. Jill Carlton and I'm a Senior Research Fellow at the University of Sheffield in the UK. Before I start, I'd like to take this opportunity to thank my colleagues and co-authors listed here. During the talk today, I'm going to try and cover three main points. Firstly, what do we mean by the term acceptability? Next, I'll highlight some of the key findings of our systematic review where we examined how acceptability has been assessed in childhood screening programmes. And finally, I'll identify some key considerations for how we should evaluate future childhood screening programmes with respect to acceptability. So, what do we mean by this term, acceptability? Well, in 2017, Seacon and colleagues proposed a theoretical framework of acceptability for healthcare interventions. And they state that acceptability is a multifaceted construct that reflects the extent to which people delivering or receiving a healthcare intervention consider it to be appropriate based on anticipated or experiential, cognitive and emotional responses to the intervention. They propose that acceptability can be considered as having 7 constructs, and these are listed here: effective attitude, burden, ethicality, intervention coherence, opportunity costs, perceived effectiveness, and self-efficacy. But what do we mean by each of those terms? Effective attitude describes how an individual feels about the intervention. Burden considers the perceived amount of effort that's required to participate in the intervention. Ethicality is the extent to which the intervention has a good fit with the individual's value system. And intervention coherence is the extent to which the participant understands the intervention and how it works. Opportunity costs are the extent to which the benefits, profits or values must be given up in order for an individual to engage in any intervention. Perceived effectiveness describes the extent to which an intervention is perceived as likely to be able to achieve its purpose. And finally, self-efficacy is an individual's confidence that they can perform the behaviour or behaviours required to participate in that intervention. Sakon and colleagues acknowledge that acceptability of a healthcare intervention can occur at any time: before, prospective acceptability; during, concurrent acceptability; or after, retrospective acceptability. Now, it can be argued that acceptability is nothing more than a measure of satisfaction, that is, how happy or unhappy an individual was with the intervention that they received. But Sakon and colleagues dispute this, and they go as far as saying that acceptability and satisfaction are 2 different and distinct constructs. They say that acceptability is different to satisfaction because individuals can report acceptability before they engage in any form of intervention. They advocate that acceptability can and should be assessed prior to engaging in any form of intervention. So now we've got a little bit of a better understanding about what acceptability is. How has acceptability been assessed in childhood screening? Well, we undertook a systematic literature review where we sought to identify studies which could be considered as having assessed acceptability. We wanted to know, firstly, how acceptability had been assessed, and secondly, what aspects of acceptability had been assessed, with an overall aim of wanting to inform our thinking for how best to evaluate future screening programmes. Our first finding was that acceptability was predominantly assessed in high-income countries, as shown by the chart on the left-hand side. And secondly, the studies that we identified in the review predominantly related to newborn screening interventions, as you can see in the diagram on the right-hand side of the slide. The majority of the studies we identified in the review assessed acceptability after the screening intervention, with very few studies assessing acceptability at the time of screening itself. In terms of how acceptability was assessed in the included studies, there was a real mix here of using qualitative and quantitative techniques. Some studies indeed included both quant and qual methods. Where quantitative methodology had been used, the majority of studies used their own questions or questionnaires or modified existing questionnaires. Some studies did include validated questionnaires, and these were often a proxy of acceptability, such as a measurement of depression or anxiety. Of the studies that did use qualitative methods, most involved interviews, and 7 of the studies included focus group sessions. Some studies issued questionnaire that incorporated some open-ended questions, and here the free text was analysed qualitatively. When we look at what was actually assessed, most studies included an assessment of intervention coherence, which is the extent to which the participant understands the intervention and how it works, and or affective attitude, which is how an individual feels about that intervention. This slide here shows that all the studies we identified in the review assessed more than one construct of acceptability, and that no study was identified which assessed all 7 acceptability constructs as defined by SECON and colleagues. So that was a very brief summary of what we found, but perhaps more importantly, what does all this mean for us when we think about how we should evaluate new or existing screening programs? So if we assessed acceptability in both existing and planned screening programs, this could really help us to maximise attendance, which in turn could play a positive impact on the overall cost effectiveness of the programme itself. Therefore, we feel it's important for all programmes to consider acceptability, irrespective of how well established those programmes might be, and that assessment of acceptability should be repeated over time. And this is really important because not only may societal attitudes change over time, but there will also be changes in populations, changes in tests available to us, and changes in the way in which we can disseminate information to the target population. Thinking about this a little more, using those 7 acceptability constructs, we need to find out how parents feel about testing, because their feelings may be linked to their understanding or not of the screening process. And if that is the case, then maybe our existing information and promotion activities aren't quite right. We also need to think about burden. So why is it that some parents attend screening and other parents don't? Is this linked to where the screening is done, or indeed when the screening is done, either during the day or indeed the time of year? In terms of ethicality, our feelings and views do change over time, and it's like that phrase, if only I knew then what I know now, and this could indeed be linked to knowledge and information needs. Similarly, parental understanding of the testing and target condition can impact upon attendance, and we have to recognise that in terms of information needs, that there isn't one size fits all solution. Alternative methods of disseminating information may need to be considered, particularly with people who struggle to read or maybe speak a different language. We also need to think about what a parent has to give up in order to bring their child to screening. And whilst the word cost is in the title of this construct, the construct really isn't just about financial implications. It could also cover issues such as missing out on spending time with other members of the family, or missing work or other responsibilities that they may have to miss out upon. How much a parent believes a screening programme will detect whether their child has a problem or not is also very important. And here, aspects such as false positive referrals and word of mouth within communities can play a huge part to influence attendance rates. And finally, we need to think about whether parents believe that their child can perform the screening test. And this too could be linked to parental knowledge and understanding. Despite childhood screening being carried out for many years, our review highlighted that this is an under-researched area. We identified that acceptability was often assessed by determining parental knowledge about the screening programme and process. The emotional impact of screening explored maternal anxiety levels, and that this was often linked to the timing of screening as well as the impact of false referrals. So some final thoughts. Well, there are definitely evidence gaps. All the studies in our review were taken from the parental perspective and often that of the mother, so more work needs to be done looking at screening acceptability, taking a wider family perspective. We should also consider trying to capture how acceptable screening is from the child's perspective, particularly in older children. And if we're looking at starting new screening programs, getting a measure of whether the proposed program would be acceptable could be incredibly valuable. The results of such studies could help determine information needs, timing of information, and so on. If you want to find out more about our review and the work by SECON and colleagues, the references are listed here. Thank you for your attention.
Questions from the floor? Yes.
Oh, thank you so much for this presentation about these soft values that are so important, both for the success of screening programs or for further intervention. And I think this really points out the importance of information, because we have heard so much about the missing or very fragile links between different parts of screening programs and further intervention, and that poses a lot of pressure on the parents really to follow up with the children, and that's if they need to have the information about why we do the screening, what it's important for, and what will happen if they don't or do follow up with their child. So children. So I think more research and more information is one of the key points, factors for success in these programs. Thank you very much.
Yes, another question? Yes.
Thank you, Jill. Do you have any information about how parents would prefer to be, mostly parents, I'm looking from the parents' point of view, having their children enrolled in the screening? We talk about opt-out and opt-in, and that has connotations regarding whether they feel that they were coerced or voluntarily participating in the screening program. And did you ask anything about that, or could you comment about that?
Yeah, that's a fantastic question, and indeed some of the studies that we identified as part of that literature review that I spoke about did examine the sort of the information needs and the processes around particular screening programs. And you can anticipate that some of the screening programs, particularly with respect to newborn screening, which is, you know, let's be quite honest, quite an emotional and fraught time in any mother's life and father's life. And sometimes they kind of felt carried away in saying yes to something and consenting to something, but perhaps not really understanding what it is that they'd said yes to. So some people sort of explored that issue of informed consent and any possible connotations that had further down the line, in terms of whether they would then engage with screening for their siblings. So I think, you know, that an evaluation of any service, whether it's established or not, has to sort of take into account these issues around consent and informed consent. And of course, informed consent can't happen unless we're really sure that we've presented information in the right way. And you know, getting massive leaflets or things through the post, we can't think like that anymore. The way in which, you know, society engages with everything, just look at how wonderful this conference has been, and we're not all physically in the same room. And the same can apply with information needs around screening, is maybe we should be thinking more about sort of disseminating with videos or short webcasts, or maybe options where people can drop in online and ask professionals about what's going to happen on the day, and, you know, engaging people in that way. Because at the end of the day, we have to get people in order to be able to make our screening programs work. And if we're not getting them in, then our information giving is not right.
Thank you very much. Any final thoughts? Maybe I do have one. I realize that there is a bit of a golden rule, and that says probably about up to 10% of your cost of a national program could go to quality assurance and evaluation. In many big programs on cancer screening, so that's a sort of a golden rule. So indeed, the issue of how much do you spend on a registration, on quality assurance, on a auditing, on a feedback, maybe you should really post a separate budget of about 10% of that money for such a thing. Anyhow, thank you very much. Huip, the timing is 2 o'clock? Yeah. Or 1:45?
1:45? 1:45.
Yep, good. Thank you very much.
Central European Summer.
Thank you, Jill. Mooi, mooi. Nee, is goed zo. Mooi. Want kan je zien hoe... Hello, everyone. My name is Harry de Koning. If you haven't heard me yet today or yesterday, I'm Deputy Head of Public Health, Erasmus MC Rotterdam, and I've been working in screening evaluation for the last 30 years. That's possible, and I'm being still alive. But in this big project, we were very honored to start doing evaluations on hearing and vision screening. This is called a jam session, and I thought first, what is a jam session? And I think a jam session is to improvise with instruments, I think. And indeed, with the modeling, we have about 7 different instruments, and I try to improvise. But I think before that, I really have to thank a lot of people. We really have to thank all the hearing and vision experts in this project. Without them, we couldn't fill in the expertise in the model at all. But I surely really have to thank at least these 2 people here on my left-hand side, Eveline Heinsdijk, who is a senior research fellow at my department, and Dennis van Aken, who has been instrumental in trying to get the models running, together with Jan Kik, and again, with all the help of all you hearing and screening experts. So thank you very, very much. It's one of the final sort of products of this EUSCREEN project, and yes, I'm really proud of it. What we have asked for to this session is whether some people could try and to get some runs going, where we in fact have screening a screening proposal, and then see what happens with that screening proposal in your region or in your country. So there are at least about 10 countries or so that really did that and sent us some PDFs to where we can go through to give you a bit of idea how it works. And we know there have many more people have been doing that, but if you then don't at the end click on give me the PDF, then we don't have the PDF. So what I suggest to do is to give you some of the examples where they go wrong actually, and some of the examples, of course, then that if you fix something, you get we think a reasonable answer. The crucial thing at the end is actually to be able to to make some comparisons, so that you think, well, should I do this program or should I do that program? And that's something you should do for yourself. Again, we will still be happy to help you out in one way or the other, but nevertheless. We got some information from Romania, Israel, Latvia, sorry, you see. Which I will walk you a bit through, is my suggestion. So let's go to Romania. I think from all these people, I think especially Lisa Rubin is here. So Lisa will be able to tell a bit of her experience and her experiences. If we go to the first one, that comes from Romania. If you want to go back, we just scroll a little bit to give you a bit of idea. Just one more back, just to give you an idea of what we're talking about. So basically we are using the visual acuity screening model and the screening program of that. And so yes, if you go to the results, just to give you a bit of what the idea of this modeling is, that at the end you try to have a sort of summary of what my program does. I'll go into the details a little bit more. But nevertheless, you can, for instance, then have given your region, they will show, I'll show you later, they will have like 10,000, they have about 106,287 tests, about 11,000 referrals, and then it says cases confirmed by diagnostic exam, and here it says percentage not diagnosed before age 6. That's a crucial one, of course. You do a program and you want to know how effective is my program, how many amblyopia cases, in this case, have I not diagnosed before age 6 as of course, a crucial success factor of your program. That is why we have the first here, the major effect, some cost, and then the ratio of that. And I wanted to show you this one because here it actually says percentage not diagnosed before age 6. It says 100%. That's, of course, not what you want. So this says this run leads to I didn't prevent any amblyopia cases before age 6. You should, of course, never do this program, of course. I'm showing you this, of course, just to I'll show you, we go to the details, why. This is logic. The moment you run something and then you get something, you think, wow, why? So if you go further, Evelyn, what did we see? Yes, almost there. Yes. What did they see? So this is Romania. They said, well, we have about 180,000 infants. Life expectancy, I don't know, but that's for this case not so important. But what did they, at that first time she or he put in, or probably didn't do anything, maybe it was, maybe, is it on zero if you don't fill anything in? Maybe. Anyhow, a wrong number. Exactly, there is zero amblyopia in this population, and that's why, of course, we are not going to prevent any case. 100% of the 0 cases we're not going to prevent. So this is just to give you a bit of an example. This is, of course, not how it should be, but just to show you that actually it does fit. If you do have no amblyopia in your region, then actually the model runs nicely, gets you all the costing information, but of course there's no effect. Small detail. So we go to the next book, because they are actually, of course, he or she, I'm not sure.
When we got results for the number of for the number of cases that weren't diagnosed before. I wasn't sure how that was generated. Whether that was, is that dependent also on the percent of cases that didn't come back for the second or third screen, the coverage, and also the prevalence rate?
Correct.
I mean, I didn't understand where it was generated from.
Sure, fully understand that we don't have everything in. So it's been, how do we say it, under the hood of the car it is, but you can't often see it. So indeed, in the presentation that Evelyn showed, we first try to really estimate what is the prevalence of amblyopia and the different types in time. So between well, we start at, in this case, do we start at year 0? Or 3, anyhow. But so indeed, the curves that you showed before, based on the observation of studies, gives us the idea of, okay, there should be so many cases in your population, and you can then, for your different country, change a little bit. But so that's the basic thing. What is the incidence of the population of amblyopia? And that can be a bit bigger and a little bit lower, perhaps, but it is based on these data. And then you're right. Then the second thing would be how many people come, what is then the sensitivity, how many people do I pick out, will they be referred for treatment, and how successful in treatment. So you're right. The final number actually is indeed roughly prevalence times coverage, times follow-up, times treatment success, which you're right, is all under the hood. Yeah.
Thank you.
But true. But so if we go now, this is the correct one. Maybe you go to the amblyopia first. Sorry. So apparently here they filled in the 3% prevalence of amblyopia. Again, in fact, it does have that nice curves per type that we put in. If we then go to the results, indeed, again they have in this case 150,000 tests, 28,000 people, children referred, and actually given what they do with sensitivity, I'll come back to that in a minute, actually this program then basically says I do not find about 30% before age 6, but I do find 70% basically, and with some costing of course, and then basically you get a certain amount of cost per case detected. En de collies is helemaal net op de frontpagina, hè, geloof ik. Correct? The last part of the table, sorry Evelyn. And so actually, given the estimate on quality of life that we took into account and discounting, actually it here now says we have about, the program costs in this case about 2,500 euros per QALYs gained. So taking into account how many children did I find, how successful is that treatment, I give them that quality of life loss, that utility loss, the 1% lifetime that Evelyn showed, and the costing, actually then you get a range of this for this specific situation. I know it's a lot of steps. We still have to make something clear.
Can you summarize
Yeah, so in that sense, this is what it's being described in words. It basically says that in this situation, I have about 150,000 tests. Each test costs about €7. With my program, I refer about 28,000, 29,000 children for further follow-up. And in fact, I basically do not detect about 30% before age 6, but I do detect 70% basically before age 6. And then basically it means it costs about 4,000 per case detected, or about €2,500 per quality of life adjusted life year gained.
More questions?
Yeah. No, please, because I know.
In cost utility and cost effectiveness, but has there been any work that's been done on calculating the number? Because I mean, I know that they say, well, if it's $50,000 in the United States, then it's cost effective. Below, more than that, throw it out. But doesn't it have to be adjusted for the GDP?
Yes.
Of the country?
Yes. So sometimes. So
that's all.
There is yes. So there's first of all, there's not a clear cut border that you say now it's not cost effective. Now it is. In general, there's almost no minister that dares to say, okay, if it's this and this number, I will not pay for it, or the health insurance. So in general sense, there is a sort of feeling what is reasonably appropriate for your country. And that's why indeed the US, it's 50,000. They now debate that it should be maybe 200,000 actually. Yes, no, just to let you know. In the Netherlands, often they use the 20,000, and we are proposing that's really too low. It should something be like 35,000. The UK has nice guidelines, and the average ratio for things that they agree upon in healthcare intervention is about 35,000. So to give you about the idea. But you're right, in general, for all countries, there is the debate versus whether it's one time the domestic product, the general domestic product, or 3 times the general domestic product as a cutoff. If it's one time, then it's very cost effective. 3 times maybe the border or so. So that is sometimes what the WHO uses. So you're right, you could look for your own country and say, well, anything that is above the level of 3 times GDP, then you may think, well, I'm not sure. And 1 times GDP is very cost effective. So you could use that, certainly. So in general, something like, in this case, something like 2,500, that is simply cheap. If this is the correct answer, of course, but nevertheless, this is cheap. Again, just to give you an idea, for the Netherlands we have quite a different number. Again, there are some things wrong in this calculation, but just to give you an impression on how to do it, sort of, and where do you run into, and is it correct? So if you scroll a little bit further down, maybe, then actually the nog verder. So in fact, here are then the details what they try to do. So they are actually, in this case, they're doing a preschool screening at age 16 months by an ophthalmologist. They assume a 90% test sensitivity and 83% test specificity, about 10 minutes duration of the test, and about 85% attendance rate. That's what they now use to give you a bit of impression of what they filled in, basically. Yeah.
I think it also gives the numbers of detected and how much it costs per detected child is also above that. I think when the QALYs is still also there is some insecurity, but you can go a level before that.
Yes, correct. If you're not sure about what the effects are, you can stop there.
Yeah.
In principle, I personally find that wrong because yeah, I mean, what does mean €100 per child with scoliosis being detected, for instance. I mean, your point is well taken, so I'm not going, it's really well taken, that you're right. If you don't know the consequence later on, you should somewhere stop, indeed, in fact. Then it's better to stop than assume something that is also wrong. So you're right, if you go back, you're right. So if you go back, it actually here says, indeed, these are the amounts of costs. So you need about, where are we, number? So you need about, is this probably 1 million? Cost of screening, cost of treatment. This is cost per test. The total cost 7 million or so. And you're right, the cost per case detected is 4,000. And you're right, then you still can do in your head, think, well, 4,000, and what does it mean? Well, this is probably quite okay for a child. So you're right, yes. No. So I'm sorry. I don't want to offend you at all. Maybe I should rephrase myself and say, I urge everyone to think then about those consequences and try to get the correct answer for what is next. So that's why. And again, there are basically only two big, nice studies for amblyopia and the consequences to use, and that's really, really great, because without those you indeed certainly have to stop here. But anyhow, this is how you can do it. Yeah? And so indeed, under the hood, it is the prevalence, how many people come, how many children are being referred, and how successful is then my treatment, is all underneath this. So the moment, in this case, this is screening at age 16 months. If they would fill in, let's say, if they would fill in, I get screened at age 12 years, and then the model itself then says, well, the treatment success, I have, again, lots of people maybe even detect a lot, but the treatment success is so much lower that there will be a lower effect, because that is what is under the hood is happening. Yeah.
Below that,
yeah.
Because then you also include the treatment, but not the QALYs, so then you are one step further.
Yeah. Okay. Thanks. Yeah, that's an addition. Yeah. Yeah. Helpful so far. Yeah. Good. So if I may go, I'd like to go to Israel. So we had now Romania, basically showing. If you put something wrongly in or didn't change the zero prevalence, of course, it doesn't work. Well, the model still works. Lisa has really done a major job and sent about 10 PDFs almost. So, but we thought I'm going to at least show you one or two, and then maybe you give some feedback what you found difficult or so. So just an example on neonatal hearing screening for risk babies. Next slide. So again, the same sort of structure, the number of tests, the number of tests in the second round, so in either with a different machine or a different test, then the total number is, of course, adding those up. And here it says, for instance, the percentage of substantial hearing impairment. I don't know where the cutoff here was, but thank you very much, 40 dB. It says, actually here, it says, given this program, we unfortunately do not diagnose this hearing impairment in 6% of the children. And so in 94% of the children, I am, let's say, in time. Yeah. And then again, the cost per case detected. I just try to, sorry, one more back. No, that's fine. And then, this is the one. So sorry for these are, of course, no question marks, but it's Israeli. It's not the euro. That's a wrong PDF thing. Sorry. So this is just, it says, of course, Israeli.
Well, we had a lot of trouble doing the one for risk because we don't, although we divide up, we ask for the reporting, for instance, and we have different protocols for risk and low risk and high risk, but it's the same machinery, it's the same staff, and I couldn't, you know, I have absolutely no idea of how much is dedicated to
the risk kids and how much it's all in the same hospital.
Yep.
So and the other problem that I had was, but that we sort of took care of, but it's not really, is that when I was doing it on these rounds, I can tell that I couldn't figure out how to get the right answers using the data that we had we do 1 OAE, 2 OAE, well, it's if you fail the first one, and then the ABR, and I couldn't get that to work at all, which I figured out afterwards. So you see nobody in the third round, but that's because I couldn't figure out how to work it. That was just my inability to understand it. So this was very difficult for me to fill out, and I couldn't. And then for the costs of the diagnostics, which we did over again when I did it with my audiology expert together, we have a list of what things are supposed to cost and whether you separate out the doctor's visit from the test and stuff like that. What its relation is, the cost list, to what the cost actually is?
Yep. No.
Your guess is as good as mine.
Yes.
I don't know.
No, this is unfortunately well known in economic analysis that especially in healthcare, of course, that sometimes you use a costing item that you know of but that is often not the actual cost. It's a tariff or whatever.
And this doesn't have here, I'm just looking at, because it doesn't have here the treatment costs. And this is just the diagnosis cost. And the treatment cost was, I don't have a list. That's totally black box.
But again, it then would still give you a reflection of what's going on, and that if you say, well, I just pulled in now 10,000, but it could have been 100 versus 200,000, you can see what will happen and how sensitive it is. I know you don't want to do that every time, so I realize that, but then still it gives you an idea about how sensitive that part actually is. If you keep everything on, you get one PDF, you then basically have the summary table, and now you put one major cost item that you're really uncertain of, you change that, maybe times 5 or so, and then see how important it is, because sometimes it is maybe not even so important. Not every item is important. Maybe a big one, but if it's only for a couple of referred children, then. So I'm not saying that we should do that with every item because it's undoable, but sometimes you could even do so and say, well, but this is, I think, I wonder whether this is the major cost item that I need to know from anyone in my hospital, whatever, and you could actually change that, do another run, keep everything same and see, well, it's not so interesting. You see what I mean? Because then it would actually be possible that at the end, if you nog een keer de kost per laat zien. No, okay, but nevertheless, you get a cost per case detected. Again, sorry for the question mark, that is an Israeli money, I think. And then it would say, in this case, 1.8. And now you do the other one, and it suddenly now says 1.9. You think, that's not the issue. It is an important cost item, which I'm uncertain of, but at the end, for my decision, it may perhaps not be so important. Maybe, I don't know exactly now in this case, but maybe the cost per test is much more important, or the cost of the device. So you could even play around with that. And with play around, I mean simply to wonder how important that variable or parameter is actually. So this is then an example for the NICUs. So indeed, I realized I heard you had quite some back and forth. So that's really that's really good. And so indeed, that especially disentangling issues within your hospital or within the children is simply always quite difficult. Good. Is there something else you would like to see?
Well, I don't know whether if you're going to show the other one.
Yeah. Well, we have them. So which one
show
would
the other one? I have some. I just had some thoughts about what we could do with it, because I did it together with
one of our most senior audiologists, who is our consultant for audiology, and we did it according to her data for her hospital. But each hospital has, when we based, in terms of upkeep and all those things, and that was, it turns out that they use a tremendous number of probes because the people that are doing the testing are actually these young girls that do it. They're trained for a year. They do it for their national service, and then they repeat, and they're losing probes like water. And that it might be, so I don't know whether they're actually, first of all, in terms of national, I don't know whether it's accurate, but if we did it, we tried to do it, when we combined the high risk data, it would be, we could actually, if we tried the hospitals to give us more accurate data, because it turned out I don't think that the equipment is the most expensive part of the thing, but when you collate it all together and then you weight it, it might be.
Exactly. So in that sense, that's why you could.
It's actually an interesting tool for the hospitals to judge themselves.
It is a dashboard then, basically. Getting the feedback back, and you see, listen, we are very uncertain about this costing item, and you see how important it is. So you could use it in that way, and then just change one or two of the parameters and see the difference.
And we also have it because we never said what, the people are supposed to be trained, and it's mostly audiologists who do the second stage of the testing, but the first stage of the testing, there's a whole gamut. And it could be used to explain, to look at each one of those. It could be used as a quality tool in and of itself.
We could try it. Whether there was something that specific other ones that you would like to do?
The last one that I did, that I sent in.
The what? The last one?
The last one that I sent in.
The inhaler from well babies, maybe? Is that what you would like to see?
Which one does it say? Yeah.
Yeah. Shall we do that? Let's see whether that.
What's the date on it?
Yeah, these are the last.
That's the last.
This is the last one.
This is the last one.
This is the last
one.
Right. Yeah?
So
So this is now the example, not the high-risk children, but this is now the well baby.
No, it's all the children.
Yeah, exactly. Yeah, okay,
it's all the children,
all children,
and then I weighted it.
Yes, okay, that's good.
I weighted it. I estimated to a certain degree, and then looked at our data according to the data that we had, and tried to weight it when I put it in. So
then it would be something like 170,000 first tests for almost 5,000 second tests.
Oh no, this is just well babies. If it's 169,000, it's just well babies.
This is well babies.
Because I did it afterwards on all the babies, I think.
Yeah, okay. And then here we see in the this is the well babies. Then here it says 50% not diagnosed before age 1. Cost per case detected 34,000 Israeli money, I think. Cost per test 14. Misschien ga je, als je even naar het programma gaat, misschien dan kunnen zien wat er was aangenomen. So this was now, in this case, the example that was filled in. Age 1 in this case is, what is meant with the 1 is day 1?
Day 1.
Yeah, day 1. Yes. Day 1 OIA, day 2 AABR.
Right.
Dedicated screener technician, 95% sensitivity, 5 minutes duration, 95% sensitivity, 10 minutes duration. And this is the 85% coverage or attendance for follow-up investigations, for diagnostic procedures. And as an example, 85 OA devices needed, 34 AABR devices in this. No, again. We are happy to work further on that. Yeah.
What you put in on this page is really what is then gives the outcome.
True.
Because if you have the attendance rate, if that is low, you will have a lot of children that are not detected before 1 year of age. That affects that number. And for the duration, time of the test and the specificity will affect the cost very much. So I did some different runs with put in different figures.
Yeah. Yeah, no, you're completely right.
I didn't send them specifically. I thought you have them, but
yeah. So I wanted to sort of show the sort of final results, and often you then, of course, have to look carefully and think, hey, can this be okay? But you're right. All the details on what you are going to implement and therefore have as an effect is primarily in this one. Huh? It's about indeed sensitivity, specificity. If you know order of referral rates. Here is the profession and therefore salary cost at some point, the devices, the timing indeed, and again the 85% here means follow-up investigations for referred children is what it's meant to say. I
think I was really surprised first time when I saw so many. I have this good program and so many weren't diagnosed. And then I realized if you have like 95 for 4 several steps, consecutive steps, that will have a great impact on the number of children not diagnosed.
Exactly.
Yeah, I've got this question a lot of times. So, and each time the answer was, well, if you multiply all those things, then you get this answer. Yeah.
I think it is also a good example why initially the results for Albania, I think, were. Let's say, well, at first look maybe also counterintuitive, because it was about what happens in each step, and if there's too low coverage or too much loss of follow-up, that really multiplies, and then of course not with successful treatment, of course. So it's crucial that a couple of percent makes a difference. Yeah.
Something I think that many people, if they don't have really been working with the screening program, they underestimate the time for doing a test. And I also thought about that for the vision screening programs, that, I mean, doing just the test, doing the OAE, takes less than 30 seconds, but you have to go there, you have to put the probes in the ear, and you have to find the child, and there are so many things around it that it takes, I mean, so many more times than just doing the test. If you have a row of babies lined up before you, you can do it very quickly, but that's not the situation.
Exactly. It's every screening program, every new cancer screening program, every new screening program, every healthcare intervention, of course, anyone says, oh, I can do this in 3 minutes or so, and then you say, yeah, in the ideal situation, that specific child or so, but it's the whole process.
You have to have the people in place, and some babies not there at that time because they have gone for some other visit with the doctor, they come back later.
So it's a good example why we have always said for the vision screening, or initially, let's say, when we thought it was effective, having screens at early ages, we have always said, yeah, but in a running program of Well Baby clinics, adding this, it's a relatively easy part. Mm-hmm. So, and we did really with timesheets and so, and then it appeared, it's in time. It's not so important if you have already an existing program, of course, of something. So that's why we take that into account. Are you going to have a new situation, or are you adding it to something that really makes it?
But at least that is also in this. You can say if it was together with some heel prick or some other test or just other, does it affect the calculation in the model? If it's a separate visit or if it is together with something?
Yeah, so what you fill out here doesn't matter for the model, but it's more to let you think about the duration of the test, or which professional or the attendance, because that all matters whether you combine it with other screening or not.
So if it says birth heel prick to the left, or if it just says other test occasion, it makes a difference in the calculation.
Yeah, no, it doesn't give a different calculation. It's just to for your own administration and thoughts what you should fill out in the line there.
Mm-hmm. So it maybe should, but
in
the visual acuity screening, we do take into account the duration, or not?
Yeah, we do take into account the duration.
Yeah, then we take into account duration. In the costing. Yeah, okay. So at least this is a bit how it works, and again, I know the experience is, of course, always that the first time you do this, you have to have the interaction, and then these are often not the correct answers yet, but that's fine. It just gives you, and you can make comparisons. So if you make a mistake with something, again, make the comparison with another program. You probably make the same mistake, but nevertheless, you know how they compare. That's the I think that's the goal and the strength of these kind of things. And of course, also comparing, in this case, comparing hearing with visual acuity screening or so is really also helpful to that in that extent. Shall we maybe do, yeah?
Maybe it's a little strange question, but if you think to implement or set up other screening programs, not for vision, not for hearing, do you think about the same principles apply? I think yes, but
yes.
What's your opinion?
Yes, my answer would be yes.
Okay.
So, and as you may know, I'm biased. We have started with these kind of programs in breast cancer screening first and cervical cancer screening first, and the idea is simply to get the best estimate of the natural history of the disease or the risk factor or whatever. And surely, therefore, you need good quality data, you need possibly trials, you need observational cohorts. But the idea is indeed, if you get the best guess of how your disease or risk factor works and what screening does on it, that's basically, and whether one screen or two screens or 6 screens. So that is why I really think, again, you need, it is not cancer, let's be clear about that, but you get these expertise from hearing and vision screening experts, then you can make a reasonable model about, in this case, again, the natural history of amblyopia or development, maybe should I say. So I would believe that indeed that a hip disorder or something else, or language delay, I did a big trial on language delays in children, could be done the same way.
Yeah, because I was, not anymore now, but I was involved in Flanders in yes or no setting up the pulse oximetry screening for babies.
The what? Sorry, the
pulse oximetry screening, so
yeah.
saturation measurement
Yeah.
in a certain window after birth to detect children with a critical congenital heart disease. And okay, your model was not there.
No.
But I'm wondering, it would be interesting to see those who have chosen for it, if it's, if you can test it with this model as well. Would be great to see.
Would be great.
Because some countries apply it, some don't. So, okay.
Yeah, and so again, I mean, the idea is also you can also show what you should not do. So we there was screening for scoliosis in many well baby clinics. There was almost no data around. There was no trial. There is one brace trial, one treatment trial now in the US, which gives some indications. So you can do then this kind of model and basically show that you should not do it also. It can go both ways actually. So yeah, just to give you an idea, we now have these models for like, I think 10 cancers. We have it for cardiovascular disease. The hearing and the vision is really new. And yeah, we think it helps. And it's not easy, I mean, but that's fine. So maybe yes, good. Maybe we go. Shall we? Was another question? Otherwise, we'll go to Letland. To the first one now. To give you again a bit of idea. Visual acuity screening for Latvia. And this is then the first result. Let's see where that is. The cost per case, yeah. So here, thanks. So again, filled in numbers. They thought the number of tests, number of referrals. Here they had as a result percentage not diagnosed before age 6 about 50% or so. So, and we'll see so in a minute probably why. But if you then just go to cost per test, 32 is already quite something, of course, I think. And then it says, indeed, cost per case detected, 12,000. That's quite huge for this. If you've seen the runs and so on, and you know a bit what's going on, then the first thing you see is 12,500. 32 is already quite a lot, but 12,500. So if you go on, then we, of course, spotted what the idea was. So here they did, again, what was the no career? The no?
Yeah, that is not combined with other screening.
So they did two things at age 36 and age 72. But here you see, for instance, the duration of the test, 40 and 30 minutes is what they put in. I don't know why, it doesn't matter so much, but that does have an effect on the costing.
Optometric examination. That was my question yesterday. that an optometric examination may take 20 or 30 minutes to do a full exam.
Okay, okay. So that's but then it's important to sort of realize that and compare that with other things you get in that says, oh, it can be very cost effective or much cheaper. And in fact, if we go to the last one maybe, apparently one way or the other they did change it, and we didn't have, did you have feedback to them? No, I think they did it themselves.
Yeah.
But this is a good point. Welke was het dan ook weer? But actually in this one they also sent a PDF in which now cost per case detected is 2,500 instead of the 12,000. And if you go further now they did say the 20 minutes. Again, maybe the one is the correct one, is what they're doing at the moment, and they wanted to see what happens if this amount, if this time and therefore cost really changes, how much does it matter? So this is an example of what we maybe debated in the beginning. So here you see how that then basically immediately influences the results. Do we know how? Yeah, here it says 100% sensitive specificity. So do we know why they are relatively? Where is the? Yeah, oh, here now they have 20. Oh, now they have 26% not diagnosed before age 6, and in the early one they had 56% or so.
Yeah.
And then they probably had real different numbers here. Then I presume.
Yeah.
So. Again, just to show you that it sort of works, that then if you change something because maybe, so in this case, that's a good point, maybe they try to see what would be my optimal situation, 100% sensitive specificity, not the 40 minutes.
So the discussion is that if you have a full optometric examination, it's more expensive, it takes more time, but you reach very high specificity and sensitivity.
Exactly.
And they have no orthoptist yet.
Exactly.
So that makes lots of difference.
Good point. So that's the comparison then you can make. What is then now here my cost per case detected? Am I fine with that? Indeed, I find more cases. This is the difference indeed. Nog een keer, hier dit was de 26% denk ik. Hè?
Ja.
Again, the result here was 26% not diagnosed before age 6, whereas in the other one we had something like 52% probably. Misschien dat we toch nog een keer naar die gaan, naar de vorige. Mag dat? Kan dat nog? Because then we can see actually what they filled in that. So here you see indeed 54%. And this is what they filled in. Only you think, or did they do something different here?
Yeah, so I don't see here in the PDF the attendance at diagnostics. I don't see the attendance to diagnostics here in the PDF. So maybe there they filled out something.
They must have done something there probably, but we can check. Yeah, nice. Yeah, so it's a nice example. Okay, we have that situation. It's true. We're doing it then probably very, very good. Probably a bit expensive. But this is then my ratio. If I'm fine with that ratio, then I have more. Then I basically have more children detected earlier with more success at a reasonable cost. So that's how you can compare then the programs itself. Yeah, thanks. Good.
We have a question in the chat.
Very good, very good.
Yeah.
Do we know what the question is?
From Zia, and I think she can ask it herself.
Oh, okay. Let's try that.
I'm sorry, I tried to ask and I thought that nobody heard me, so Dennis asked me. Now the question that I wanted to ask is that when do we choose test specificity and when do we choose expected referral rate? Because I found that confusing. Because expected referral rate is an outcome anticipation, while the other one would be the test per se that we choose. So when would we do that?
Yeah, thanks. So do you know her name exactly, yeah?
Zia Chowdhury from New Delhi, India.
Yeah, thank you very much. And your question, I think, was about either the specificity or the referral rate and false positives, I think, correct?
Yes, that is it. When do we choose that in the
model? So I know, and I have no verdict on it, but I know we have been debating that for 2 years now. The point is basically in the model we can use both. and they come up with finally the same answer. So if you know the one or the other, you can work with that in the model. The point is, you're right, specificity is often a very important test characteristic, test performance characteristic, but often people don't know it. So how do you know what the specificity is? Then you really have to make a 2x2 table and know how many people did I refer, how many were, etc., and what happened in the next year or so. So often people then just put a number on it. So I'm not saying that you are doing that, of course. Let's be clear about that. But sometimes then people say, well, it's probably 95% or so, and we can use that then, because if you don't have anything else, and you know from other programs they say it's 95%, we really can use that. But on the other hand, you could say, well, often you have a cohort or you have a screening program, and I know how many people were referred, or how many children were being referred, and how many were true positive and false positive. So sometimes people actually know that number quite well. And again, we can use that both. Correct?
I sent my PDF. I sent it with the expected referral rate because I found it very difficult to determine specificity.
Yes,
that's the reason I asked this question. So I did it with that.
No, correct. So, and again, true, if you have good high quality data, of course, you can calculate them all. So then you often do know the referral rate, the false positives, true positives, and then you can make your 2x2 table. But if you know the prevalence, you have to have an assumption on your prevalence, of course, too. But therefore, we have a nice paper now. So thank you for this question, because you're right. It sounds often easier than said. Yeah. So thank you for the question. Yeah.
Thank you, Doctor.
Good. Other questions? Were there things you were really missing or so? That's silence is good. With this question, silence is good. Good. Nothing else in the chat dan nu, Dennis? Evelien? Wat? Niet? Evelien, had je nog dingetjes samengevat?
No, we had done the 4 we selected.
Yeah, okay. So yeah, if not, I think I had never done a jam session, but now I have. So thanks, Huip. Thanks, Huip. And thank you. Ga jij afsluiten waarschijnlijk, hè? Met jou.
Okay, dan hou ik hem wel zo vast. So, I think we have now reached the end of the Congress. Is that correct? Or are there other programs? No, huh? So, I think we really had a good meeting. Of course, because of the COVID restrictions, many people did not come. I got a lot of emails of people who were really sorry that they did not come, especially from orange countries. And now we have several people in, not only in orange dress, but also from orange country. And they tell us all that they had no problem with the customs at all. But we did not know beforehand. For instance, people from Turkey absolutely wanted to come, and it is a pity. But on the other hand, if the Congress would have been held last Thursday and Friday as originally planned, we could not even have had this meeting, because we were then limited to 30 people with far more regulations. And fortunately for us, the regulations changed last Saturday. So that is very fortunate. Also, there have been a lot of people watching on the internet, and all the sessions can be viewed again, and also the concert by Nora Dudec and by Anna Lachey and by our star recorder player, old music, Evelien Heijnstijk. It can all be downloaded in DVD quality. And now I must please stand up, Dennis. There is one, and the boys at the back, can they come forward?
I think so.
Yes. Yes? They're working. Yeah. Oh, you're a slave driver, just like I am. But this is really what this man has done for us, the internet broadcast, the development of the model, the development of the website, the development of the database. And I was really, you know, I tell you what my secret idea was. I mean, I was so busy I couldn't do, you know, I wanted to do a procedure with a doctorate and put the rope and the hat, but because that's really worth it. But what you have done for the study, the way you have collaborated with Evelien was really fantastic. I think we should give one special applause just for you.
It was my pleasure. Thank you.
And there are 4 boys in the back, and they are absolutely fantastic. They did really all the work, and it was absolutely gorgeous what they did. It was very fortunate that we could take them to the Congress dinner, and all of them climbed up in the windmill of my grandfather, which they really enjoyed tremendously. I think when the meeting is over, go at the back and don't shake hands, but thank them, because they did a fantastic work. But so many other people, I mean, Mandy Nordman and Jan Kik are still calculating the expense claims, which have all to be finished tomorrow afternoon. So many people contributed, all the country representatives who really enthusiastically supported filling out questionnaires, reporting back and forth. I mean, it has been a wonderful collaborative effort. And in some respects, the corona pandemic even was favorable for the study, because we have far more web meetings. So that really helped in the speed of development of the model. That really helped. Yes, that really helped in some respect. What we have not discussed is the manual for implementation of screening programs. What we had envisioned, should we have had 70 people here as originally planned, is that we would have a roundtable session discussing the manual for implementation of screening program. And it is a booklet, a PDF that can be downloaded with 11 chapters telling you exactly what you should do if you would implement a new screening program. And that also has been much work, especially by Jan Kik, who is really the great editor behind the scenes who collated the whole book. So I thank you very much, and there will be no other meeting after this. But the model will be 4 years online, the manual will be 4 years online, and all the recordings of the meeting will be 4 years online. Thank you very much for coming.